presentations right there to visit. After that, we'll have lunch, then we'll come back for the final presentations and have a time for questions and answers. Then the final session will hold immediately after that Q&A session. Dr. Awuno.
Thank you very much, sir. The chairman of the scientific sessions, members of the association, distinguished ladies and gentlemen. I'm standing in for Professor Stephen Obepa Agba and his team. He had to travel yesterday, so he called in to make this presentation. The members of the team include Professor Stephen Agba, Petra Ideawe, and Evangeline Olohi Agba. I'm Dr. Nyemike Awuno of the Department of Community Medicine, Delta State University, Abraka, and the Delta State University Teaching Hospital, Ogara. And now this is the title of this presentation is the impact of quarry dust exposure on lung function amongst residents of host communities in Edo State, Nigeria. So it focused more on the environmental aspect while leaving the factory to the people that live around the factory. This is my presentation outline, discussing the quarry operations and ending with recommendations. As a background, quarrying is a major source of particulate matter. The PM2.5, talking about the micrometers of the particulate matter. When it's less than 2.5 is the PM2.5. When it's less than 10 micrometer is the PM10, particulate matter 10, and then the total suspended particulate. Now, dust contains silica, feldspar, carbon, and heavy metals. Now, chronic exposure leads to respiratory impairment. And host communities, often unprotected, face the brunt of this exposure. Now, for the workers in the quarry, there should be some level of responsibility of the workplace concerning them. But for the host community, they might not even be aware of the risk to which they are exposed to. It should be noted that air pollution contributes to millions of deaths annually. And the quarry dust is known to have several health effects, acute, like the irritation, cough, wheeze, and breathlessness, and chronic, including bronchitis, asthma, COPD, silicosis, and there's increased lung cancer risk with silica exposure. Now, what are the characteristics of the quarry dust? They comprise particles that range between 1 to 75 micrometer in diameter. When it is 10 micrometer and less, it's inhalable. It's described as inhalable. But when it's less than 2.5, which is really a problem, we describe it as respirable. And so it penetrates deep into the lungs, causing inflammation and immunological response sequelae. And it contains crystalline silica, which increases silicosis risk, which is a chronic obstructive pulmonary disorder or disease. It also increases lung cancer risk. There's also increased lung cancer risk with silica exposure. So the health of residents in close proximity to the quarries is a public health concern, and it should be seen as that. Now, the effect of exposure too in occupational subgroup is well known, and that triggered this project. But the extent of exposure in host communities is largely unknown in developing nations. Air pollution contributes to millions of deaths annually. Now, by the WHO, particulate matter exposure linked to COPD and asthma and then lung cancer. And developing countries with our weak health system are most affected due to weak regulation, surveillance, and even treatment modalities. A conceptual framework, very useful, is the environmental risk cell concept. Look at the diagram like an onion with a center. The quarry side means the occupational setting. And then around 0 to 100 meters is the first zone. Then 100 meters to 500 meters radius around the query is the second zone. There are risk zones. And then the third zone is from 500 meters to 1,000 meters or 1 kilometer. So this study sought to do these measurements in these zones. The aim of this study was to assess dust exposure and respiratory problems among residents in host communities in the query sites in Edo State. Now in Edo State, the query sites, Edo has Edo North as a senatorial district, Edo South, and then the Edo Central. Now it's in the Edo North, the Ukbila area, that we have those queries, and they are scattered. Indeed, there are 4 local governments where these queries are cited. So our focus were the communities around those local governments. The study area, Edo North Senatorial District in Nigeria, rural communities hosting multiple query sites, and houses located within 1 kilometer radius of these queries. Our study design, it was a descriptive cross-sectional design. The study population consisted of residents in the 2 host communities, and we just cut across the various cells. The 3 risk zones were based on distance, which I explained earlier, and the exclusion was query workers. If you work in the query, you're out. The sampling method was household selection via systematic sampling. We used 320 respondents in the 2 communities, and we sampled 15 homes per zone for air monitoring. Spirometry was used on all eligible respondents, and data analysis was done using the SPSS. Now, exposure assessment. Indoor and outdoor particulate measurements were made, and for the indoor, it was done in the parlor, elevated by about 1 meter using the dust meter, a portable dust meter, to measure the PM2.5 and PM10 and the total suspended particulate. Observations on fuel use and ventilation in the houses were also noted and adjusted for because of they could confound our findings. Then the WHO air quality guidelines, PM2.5, 25 microgram per meter cube at 24 hours, and then PM10, 50 microgram per meter cube at 24 hours. Now, spirometry assessment was also done for the respondents using the microlab spirometer. Parameters like the FEV1, force vital capacity, FEV1, and the FVC were also used, and the predicted values were calculated. And then means were also done based on those zones. Lung function results, FEV1, I will show the results. FEV1 was lowest in zone 1. That is within 100 meters from the query. And FVC was lowest also in zone 1 at 81.04 with the standard deviation. And the ratios indicated restrictive and obstructive defects. From the questionnaire among the respondents, the respiratory symptoms that were elicited were cough, phlegm, wheeze, breathlessness, chest pain, nasal irritation. The high symptoms were in zone 1, cough, 57.5%, wheeze, and these symptoms decreased with distance. Remember, we're working with 3 zones: risk zone 1, risk zone 2, and risk zone 3. So multiple symptoms were common in zone 1. Breathlessness, not significantly different across zones. And indoor pollution, fuel type, also influenced symptoms. But that won't be the focus of this presentation. This result, this is a table showing the distribution of indoor levels of suspended particulate, PM2.5 and PM10, and total suspended particulate by risk zones. So in the columns, risk zone 1, 2, 3, the mean and standard deviation of those readings, and in the row, PM2.5, PM10, and TSP readings. Now, if you just look at it, it was done as a cross-section. The zone 1 has a higher reading, and it tapers to zone 2 at 61.47, then to 50.20 for the PM2.5 reading. A similar thing could be seen in the PM10, and then the TSP. Now, distribution of outdoor levels of suspended particulate matter and total suspended particulates by risk zone. Again, we can see at zone 1 is highest, and then it goes down, though the drop is not that dramatic, but then zone 1 is 43.93, and then zone 3 is 39.37. It can be seen more with the total suspended particulate. It's quite dramatic at zone 1 at 112 to zone 3 at 87.27. Now the results, continuing. Indoor dust level versus outdoor dust level. Now, indoor PM2.5, highest in zone 1. Indoor PM10 and TSP, highest also in zone 1 because of their proximity to the queries. Values are above the WHO limits across all zones. So it's still a problem, irrespective of zone. And differences were not statistically significant across the zone. So we could describe, but we could not make a strong inference. While for the outdoor dust levels, the PM10 and the TSP were highest in the zone 1, closest to the query. Significant decline was observed with distance. And then the outdoor PM10 and TSP, there was a statistically significant difference in those measurements. Now, lung function parameters across the parameters of respondents across the 3 zones. Again, zone 1, zone 2, zone 3, and then the F-test, the ANOVA, to see if there's a difference in the means. Now, for FEV1, the actual reading is above, and the standard deviation is below. So for the first one is 71.04, and below, the standard deviation is 18.19. Now, follow it down to zone 3, 82.88, and then the standard deviation is, that's quite wide, 103.21. There was a statistically significant difference in the FEV1 readings across the zones. The forced vital capacity, we also noticed that difference across the zones, and same for the ratio of the FEV1 and the FVC. Now, FEV1, percent predicted forced expiratory volume in 1 second. FVC, percent predicted forced vital capacity. And then the ratio, the percent predicted ratio of forced expiratory volume in 1 second and forced vital capacity. Now, lung function patterns. We have look at this qualitatively using so it's a table of lung function classified as lung, as normal, obstructive, or restrictive, based on our readings per participant. Now, you will notice that for zone 1, normal was 42%, obstructive was 33.7%, and restrictive was 23.7%. For zone 2, normal was 64% proportionally. Then obstructive was 15.8%, and then restrictive was 20%. While for zone, normal was highest proportionally, 74.2%, going down. So we noticed that trend, providing evidence. Now, probability of developing an abnormal lung function by zone of residence. Again, it's showing exposure zones, 1, 2, 3. Remember, zone 1 is less than 100 or less, zone 2 less than 100, zone 2 100 to 500, and then zone 3 is 500 to 1,000 meters or 1 kilometer. So we have our values and then the odds. So people in zone 1 had a 58% odd or probability of coming down with abnormal lung function. It dropped to people in zone 2 at 36%, and it even dropped further for people in zone 3 at 26%. All these have implications for recommending policy to government concerning building laws and all those kind of things. Because again, it's still the vulnerable that stay in these areas ignorant of the risks they are exposed to. And when these things happen, they don't also have the social network and the muscle to face it as it comes. And now, statistical findings. Statements. Strong association was seen between proximity to query and impaired lung function. And then dust level was a significant predictor of abnormal spirometry, as we saw in the odds ratios. Now, what are the environmental health implications? And thank God for a conference like this. We should remind ourselves that communities face continuous environmental exposure. Again, low-income populations are disproportionately affected. And it represents environmental injustice. I keep talking about the ethical part so that I'm not asked. We got ethical approval after the proposal was sent to the Ethics and Research Committee of the Irua Specialist Teaching Hospital in Edo. Before we carried all these things out, the local government chairman, there was a formal entry to them, and we got permission from the local government and then from the individual leaders of those communities before we could go to administer our questionnaire or do the environmental monitoring. We did the biological with the spirometry, we did the environmental with the dust level meter, and permission was sought from each respondent or any household that agreed to participate in the study. Now, what are the socio-economic factors? Poor house ventilation, use of biomass fuels, increased indoor dust load. Again, that is outside the subject of this presentation. And limited relocation ability, increased vulnerability. That's where they live, that's where they stay, and some of them might even have some things to do with those queries. The public health impact. It would lead to increased respiratory disease burden, reduced productivity and quality of life, and increased healthcare costs. Regulatory gap, weak enforcement of environmental laws, poor compliance monitoring of emissions, and lack of community health surveillance programs. So when this is published, we hope it will be something that can be cited to give government a basis to do some of these things. Recommendations, regulatory. We should strengthen, NESRA should strengthen its enforcement. We should enforce EIA compliance, and then mandate dust suppression technologies adequately. If we can't eliminate, we contain before we go into adjunct measures. Recommendations to the community. They are the victims, and we can't just leave them at that. Establish greater than 500-meter residential buffer zone. But these are things that government can actually do. It won't be easy. People will understand the basis of that resettlement, but it's for the good of the people. Routine air quality monitoring and health education of residents. If they know it's an issue, like what we're hearing about this lead issue, there will be an awakening, and even the government will have to act. Recommendations to the health system. Regular spirometry screening in host communities, early diagnosis and management of chronic lung disease, and smoking cessation programs. In conclusion, query dust significantly impairs lung function. The effect is strongest within the 100 meters from the work site, and there's urgent need for regulatory, community, and health interventions. I want to thank you most profusely for your time and attention. Bless you.
Thank you very much, sir, Dr. Nyemike Awuno. Thank you for those insights. We've just had a front row seat to the impact of quarry dust exposure on lung function among residents of host communities in Edo State, Nigeria. Thank you very much, sir, for delivering that presentation on behalf of the team that conducted the study. All right, so we'll move straight to the next presentation. Remember, we're going to have 4 presentations in quick succession, after which there'll be a time for Q&A. Please join me to welcome the next speakers. This is a team peopled by 3 speakers. Dr. Lanre Ajayi, Dr. Femi Ogunwumi, and Dr. Uba Onyenefa. I believe that Dr. Uba Onyenefa will be making that presentation. Please make welcome Dr. Uba Onyenefa. Thank you. So that will be paper 8. After that, we'll move to paper 9. After that, we will have paper 10. So Dr. Ngozi Madubike, please be on standby. And Dr. Israel Rezindu, please be on standby. What's the title? Huh? Okay, I'm not sure. Is Dr. Ayana Tate somewhere close by, please? Okay, you know what? Just give me a minute. Okay, it's here.
Right. Okay, fantastic. So, good afternoon, distinguished ladies and gentlemen. I have the distinct pleasure to share our experience on the field. We wanted to answer a question, and the question is simply this: can the deployment of an accessible reporting tool improve occupational health and safety practices in small factories? We did a pilot study of small-scale bakeries in the suburbs of Lagos. The work was done with myself, Dr. Femi, and Dr. Lanry. Right, let's get into the next. Okay, so some declarations. The authors, we declare that there are no competing interests in this presentation that we've done. So, our specific. So the main aim of the study, the main objective of the study was to evaluate whether deploying an accessible digital tool can improve occupational health and safety reporting in small bakeries. And the specific objectives was one, to assess the existing OHS practices, evaluate digital readiness and worker attitudes, the effectiveness of Google Sheets as a reporting tool, and to interpret adoption through technology, acceptance models, and safety culture frameworks. Right. Okay, so we designed the study in such a way as to adopt a semi-qualitative survey, and we did it in a participatory approach. And it was the sampling technique was a multi-stage sampling technique for selected bakeries across areas like Ogba, Ikeja, Agege, Shomolu, Bariga, and Mushin in Lagos. And as you all know, these are clearly areas that are in the suburbs of Lagos. And we had focus group approach before we did a pre-validated questionnaire deployment at the pre and the post-stage intervention sessions. Okay, we collected our data with questionnaires and digital hazard reporting tools, and the whole study was carried out over a 6-week period. Right. Our inclusion criteria were as follows. We wanted to be sure that the bakeries in question were categorized as small scale. And so in order for us to make that determination, it was important to look at the size of the employee size. So where we had employees that were less than 10, we considered them as relatively one-man business. But between 10 and 50 were considered small scale, 50 to 100 were medium scale, and of course, over 100 was large scale. So We wanted the bakeries to be within an employee work strength of between 10 and 50. And it was important to ensure that the people in question were not underaged, and so they had to be 18 years and older, and we needed voluntary participation. Now, another thing we looked at as an inclusion criteria was to ensure that the people who were going to be respondents had to be people who were actively involved in production activities and handling, or management of the bakery operations, like mixers, people who are engaged in mixing, baking, packaging, and cleaning. And then the bakeries, we identified certain occupational hazards in bread production, specifically heat, exposure to heat, flour dust, hot ovens. Then there were ergonomic hazards from lifting and things like that, slips, trips, and falls, and exposures to electrical hazards as well. Okay. So at least about 50% of the workforce in these bakeries also, we wanted to ensure that they had access to an internet-ready device. Most of them smartphones or shared devices for our assessment. Right. And the exclusion criteria just follows. Any bakery that employs fewer than 10 or more than 50 were excluded. Bakeries that were large, that were fully automated or large scale, we excluded them. And then if you have anybody who was under 18, was clearly excluded. And then the participant must not be one who is probably just doing administrative or external roles, not directly involved in the production activities, right? And of course, bakery owners or managers who refuse participation from their staff. Say, for instance, says, I don't want you guys to get involved, so we excluded such participants. So how did we go about determining our population and the sampling? The target population, like I earlier mentioned, were bakery workers and managers. So we sampled, we did about 125 pre-tests, and then 47 post-test questionnaires were also responded to, and we had about 68 valid digital hazard entries. So we collected our data via Google Forms. The hazard data were logged in Google Sheets, and then we did a descriptive statistical analysis of the responses. And we found some qualitative insights by thematically analyzing them. So there were some ethical considerations that were made as part of this whole process. We ensured that participation was voluntary with informed consent, and no personal identifiers were recorded. We wanted to maintain the confidentiality of the respondents throughout the entire process. So, the demographics of the respondents, of course, expectedly, most of the guys who worked there were males. About 83% of them were males, 17 were females. When we're looking at the gender distribution, when we now looked at the age distribution, what we found that the vast majority of these workers there were between the ages of 26 and 35, followed by individuals between the age of 18 and 25. So as seen on the graph, as seen displayed. And the job roles, majorly the bakers were the highest, followed by the mixers and dough makers. Then, of course, there are managers. Then we also had some other kinds of individuals, dispatch or drivers, cleaners, sanitation people, and packaging staff. So this slide shows occupational health and safety awareness. We wanted to find out if the individuals in question had some knowledge of any form of occupational health policy within their respective organizations. And we found that about 58% of them didn't even have any occupational health and safety policy. About 42% actually did have an occupational health and safety policy. And then we also tried to delve further to find out if there was any form of training or enlightenment in respect of this. And we found that no occupational health training was carried out for any of the staff. For about 58% of the staff we checked. Only about 42% had some form of training or the other that was executed during that time period. So this shows some of the common hazards that we saw in our time of doing our evaluation. We saw that exposure to heat and cold, ergonomic issues, workplace stress, psychosocial, and then, of course, there was noise, pest infestation, and wet flour, dusted floors. They were exposed to some of these hazards. So this slide shows the perception towards the Google Sheet tool. Interestingly, when we tried to assess the willingness to use the tool, we found that slightly over 50% were actually willing to use the tools. About 40 or so percent thereabout were a bit indifferent. They were not really sure as to whether or not they wanted to. And less than 10% of them were unwilling to use the tool at all. So the current hazard reporting methods. We also wanted to find out, okay, at the moment, how do you guys report your hazards? And we found that the vast majority of reporting approach was through verbal communication to their respective supervisors. About 76% of the respondents actually said so. We had about 15% by written reports, and about 9% there was no formal reporting system at all. So when we did the evaluation of the post-test questionnaire responses to assess the general use and the behavior, or access behavior, what we found that was that 100% of the participants used the tool once or twice during the study, and all of them accessed it with assistance from the research assistant. And average ease of use rating, we made a determination that it was about 4.4/5, and about 95% reported no issues using the tool. We wanted to also look at the general use and access behavior, the frequency of use. And for individuals that used it once or twice in total, there were about 73%. Those that did one to two times in a week, we had about 9.5%. And the ones that didn't use it at all, about 16% thereabout. So we wanted to also assess the ease of hazard reporting through the tool. And about slightly over 20% found it very, very easy. Slightly over 20% found it easy. Those that found it very easy as well were a bit over 20%, maybe like in 25% range. And then those that were just indifferent, they were roughly about 50%. So we assessed the perceived impact on hazard reporting and response. We wanted to see that, okay, after deploying this tool, would it cause any major change in the way people reported? And what we found was that there was no major change observed in 69% of our respondents, and 31% little increase in reporting was observed. Then, in terms of the response to the reported hazard, we wanted to see, okay, were there follow-up actions taken after these things were reported? And what we found was that about 88%, it didn't have any significant change in their behavior or in their response in 88%. And then, of course, about 12%, there was a better response in 12%. Yes, I'm almost done. Okay. So we looked at the comfort with reporting the hazards. About 40% were more comfortable. 60%, it didn't really change how comfortable they were with reporting the hazard. Then we now wanted to assess how willing these respondents would be to continue to use these tools. And we found that about 68% actually were willing. Interestingly, it's not on this slide, but about close to 50% of them also said that they would pay for a tool even if they needed to pay for a tool to do so. And that was quite heartwarming for us to learn. Okay. So we now did a comparative summary of the pre-test and post-test, and these were the key changes we observed. Willingness to report the hazard increased by 30%. When we assessed the digital comfort, there was an improvement in digital comfort from 3.8 to 4.4. OHS awareness was moderate to high. Then, in terms of management responsiveness to the things that were thrown up from the reporting, it improved from low to medium. And then fear of management, maybe retribution and things like that, decreased significantly. And of course, incident reporting, we noticed it was a small, but it was actually noticeable change. So this kind of summarizes what I just said. It just fleshes it out a little bit more so that we can see some quick take-homes. Willingness to report, basically just repeating the same things we had just said, right? Okay, so our study limitations time was an issue. That's why it's a pilot study, really. We did it in 6 weeks. The sample size, if it's bigger, I'm sure we'll get more quality data, and of course funding. So the future opportunities, we can do it, a wider coverage and larger sample size, a longitudinal study to measure effectiveness of the intervention, and we can extend the study to other small and medium scale enterprises other than just bakeries. Thank you very much.
All right. You will agree with me that those were quite interesting findings from that pilot study of small-scale bakeries in Lagos suburbs. Thank you very much, sir. Dr. Uba Onyenefa. Thank you very much. All right, we'll move straight to the next presentation. And that will be paper 9. After paper 9, we'll move to paper 10. So yes, paper 9 about to be underway. Dr. Ngozi Madubuike already on stage to make that presentation.
All right, good morning, everybody. My name is Dr. Ngozi Madubuike. We did this study together with Dr. Chinyere Umadubuike. The title is The Trend of Illicit Drug Use Amongst the Working Population in South Nigeria over a 4-year period. So what's the background? So illicit drug use refers to the harmful or hazardous use of psychoactive substances for the purpose of altering mood or creating a pleasurable feeling. And globally, the estimates for drug use has been put at 5.6% of the population aged between 15 and 64 years. This was in 2022. In 2023, the figures rose to 6%, with 360 million people noted to be abusing globally. Over the previous 10 years prior to this, the figure showed a 28% increase in the prevalence rate. And these figures were from the United Nations Office on Drugs and Crime. In Nigeria, the abuse has also risen over the years, and the population most affected are the teens and youths under 30 years. So in 2017, the prevalence of illicit drug use in Nigeria was estimated to be at 14.4% in the ages between 15 and 64 years. So 14.3 million drug users 14.3 million Nigerians were said to be using drugs, according to the 2018 National Drug Use Survey. The rate amongst now, interestingly, in 2021, during 7th annual constituency stakeholders meeting in Lagos, NDLEA stated that the rates were as high as 40% between 18 and 35 years. That's really very high. So Nigerian drug use prevalence is reportedly higher than the global average index, of course. If we have 14.4 and the global index is 5.6. So what was the rationale for the study? I remember some time ago, earlier this year, there was an article that was posted on the platform, and it generated a lot of discussion. And then I thought to myself, maybe we'll do something objective, you know. The article had stated that the drug use amongst Nigerians was really on the increase in the past couple of years. Now, the studies amongst the workforce in Nigeria, the studies are sparse comparatively. Usually you see studies done among students. Well, if I had listened to Dr. David's lecture prior to now, I may have used the artificial superintelligence and searched for more studies. Now, the workplace drug use negatively impacts the abuser, the workforce, the organization, and consequences include errors and accidents leading to health and safety breaches, litigations, loss of productivity, damage to the organization's reputation, increased absenteeism, financial losses from hiring and retraining of staff. Also, because in the workplace, in some workplaces, the drug and alcohol testing policies exist. So this is expected to deter drug abuse. That was the rationale for the study. So the objective was to determine the prevalence and the trend of use of illicit drugs amongst the working population in South Nigeria over the last 4 years, using a subset of oil and gas workers, and to determine the most abused drugs in this population, and to determine their routes of administration. The methodology. So we did a retrospective cohort study, and this was conducted in an operational health facility in South Nigeria. This facility tends to workers in the oil and gas sector. They do their pre-employment, pre-access, random annual checks, pre-placement checks, medical screenings, and this often involves doing mandatory drug and alcohol screenings. Now, data was collected, self-administered and pre-testing consent forms, laboratory screening results, and medical review officer interview notes. So the data during the medical review officers interviews, the notes were also collected. Drug tests done for other reasons were excluded. So if there was reasonable suspicion, and then somebody was acting up in the workplace, and the test was done, and this was to avoid duplicate records, because most of these people would have had their annual checks before going to the workplace. Verified negative tests were excluded from the study. So if somebody came in and ran the test and tested positive for benzodiazepines, for example, and then the person shows a prescription, that result is excluded from the study. It's noted as a negative test, because that's not drug abuse. Methodology, point of collection testing. POCT kits by Quest Diagnostics. So Quest Diagnostics is an ISO accredited and certified diagnostic company in USA. The kits, their point of collection testing kits were used to run this test. Other commercially available POCT testing kits were also used. And these commercially available POCT testing kits were to benchmark. The Quest diagnostic kits were used to benchmark these ones, as a form of internal quality control. The drugs that were tested was according to the industry or companies already existing. screening test results only were used in this study. So any results that went further to have a confirmatory analysis run on it weren't included. All non-negative results in the study were verified as such by a medical review officer. So a medical review officer ran through all the results, and these were included. And the data was analyzed using SPSS version 26. Chi-square test of independence was deployed to compare the trends over the years, and statistical significance was set as P is less than or equal to 0.0.5. Sorry, the slide is, well, these are the notes. So these are the drugs that were tested for on the left-hand side, and then the screening cutoff levels in the center. But just for comparison, we also put the confirmation cutoff levels, but we didn't use that in the study. So it was just the drugs tested and then the screening cutoff levels that were used for the tests. Now the results. A total number of 5,260 records were reviewed over this 4-year period. And out of these, 301 out of, that's 5.7%, were MRO verified non-negative test results. The breakdown is there, 64 in 2021. The mean age of abusers, or like the people who tested non-negative, was 39.35 years. But this is, a reflection of the demographics of the workforce in the oil and gas. Male gender was 98.7%, also a reflection of the demographics in the workforce and not necessarily the age of the people abusing. Okay, so the age distribution by year, 2021. So in 2021, 64% were non-negative. Minimum age was 23, the maximum was 58, and like that. In 2024, you see the minimum age being 18, and the maximum 60. So now, this is the trend over the 4 years that we analyzed. 2021, we had 4.33% testing non-negative, MRO verified. 2022, it was 6.56. So there was a slight increase in 2022. If you recall that in 2021 was the COVID period. Then 2023, 5.6%, and 2024, 6.53%. But when we plotted this, we saw that statistically, the differences were insignificant. Now, what drugs do they usually test non-negative to? You can see that THC, marijuana, tetrahydrocannabinol, 83.3% of the population, this workforce, or that's the subset, tested positive to THC alone. And then another 7.31 tested positive to THC and other drugs. So some would have THC and cocaine, THC and methamphetamine, like that. Then methamphetamine 3.32%, amphetamines 2.33%, cocaine 1%, benzodiazepines 1.33. So these are ones that's verified non-negative by the MRO. And then the other non-THC combos. So if you have people who were abusing more than one drug but not THC, it was 1%. So of the 301 non-negative test results over this 4-year period, 90.6% were non-negative to THC alone or in combination with other illicit drugs. The MRO interview notes. We extracted information from the MRO interview notes. So when the MRO interviews them, when they test non-negative and the MRO interviews them, what do they say? What's the response? These are the responses. And from the responses, we can also see the trend in the routes of the administration. But I have to also say that these responses were noted for the 90.6% of the people who tested positive to THC, either alone or in combination. So 1% was said, they used topically, 15% were non-responders, people who didn't pick up the call because the interviews were usually done via phone, few face-to-face interviews, 15% non-responders, people who said yes, that they used THC, but that they had stopped, were 7%. But then again, some tell you that they stopped one day ago, or they stopped last week. So that group was bunched in the ex-users. Then 11% said they didn't know how they got THC, that they tested positive, or rather non-negative to THC, because that's typical. So interestingly, those who tested positive, non-negative from smoking was 26%. Those who admitted, tested non-negative and admitted to using other herbal preparations, not smoking, were 40%. So these ones would admit that they took cocktails, monkey tails, abo, brownies, and all that. So this was 40% of the subsets. So discussions. So the prevalence rate of 5.75% was noted over the 4-year period. And this aligns with the global prevalence rate of 5.6% noted in 2022 by the UNODC. But this contrasts very widely with the general Nigerian prevalence rate of 14.4%. And so, probable reasons, I'm sure some of you could also add more reasons, but maybe because of strict workplace policies that exist in the oil and gas sector, so it's a deterrent. Now, personnel who came for the test, they generally had prior knowledge that they will be screened for these illicit drugs. So if somebody knows that they are going to do a drug and alcohol screening in, like, say, a week, or maybe next month, that their medicals will expire in January, they're going to do a drug and alcohol screening when they come, they are more likely to stay away and get clean before they come for the test. So that may also explain the low rates noted. And of course, unemployment increases the risk of drug abuse. So the subsets that we tested for were employed or about to be employed. So from the 4 years, that from 2021 to 2024, we can see that the trend has been stable over the last 4 years. Like I said before, one of the rationale was because of the very always publicly touted notion that it's been on the increase. So this is objective assessment. The trend has been stable over the last 4 years in this subset that was analyzed. And the objective data on the pattern or trend in Nigeria over the last 4 years was sparse. THC still remains a major drug of concern in most studies. After alcohol is usually THC. But this study didn't include alcohol abuse. It was just drugs. So, and maybe reasons for this could be because it's easily accessible, it's cheap, and then there's a perceived lower risk of addiction to THC. Another thing that was noted was that the ingestion of marijuana is commoner than smoking. When it's ingested, there's delayed onset and it has a more intense and longer lasting effect. So perhaps that could be the reason. And then there's also less stigma. So people will happily tell you that they do not smoke, that they've never smoked. But then again, they are taking monkey tails. And so for them, that doesn't count. They don't smoke marijuana and that's it. So the conclusion, there's been a stable pattern of abuse across the oil and gas sector, which is good. But then again, we could also do better. I mean, we could expect a reduction and we should work towards a reduction in the sector. Drug abuse could lead to calamitous events with far-reaching effects in the industry, and so that's why we have to push for a reduction in the rates. So more needs to be done to drive the incident rates down through education and training, well-implemented drug-free workplace policies, employee assistance programs, like we listened to the lecture yesterday. So if we have people who are in the workforce, these personnel who are helping staff who are struggling with addiction, That would also help to cut down the numbers. And then establishment of drug rehabilitation protocols would also help. These are the references. Thank you very much for listening.
Thank you very much, ma'am, for that presentation. Dr. Ngozi Madubike, thank you, ma'am, for those insights. All right, ladies and gentlemen, we have the final presentation in this set, and that is from Sims Medical Services. We have 3 people on that team: Dr. Israel Rezindu, Dr. Bukola Akintude, and Dr. Simbiat Abdul Rahman. Please make welcome the team from Sims Medical Services for the 4th and final presentation in this set, after which we'll have the Q&A session.
Good morning, everyone. I'm Dr. Bukola Akitunde, and it's my pleasure today to present to you on the topic. Today. Okay. So it's my pleasure to present to you on the topic: false non-negative drug tests to cannabis in an employee using CBD gummies in Nigeria, and the implication for workplace drug policy. So I'm sure that most of us here okay. All right. All right. So I'll just be taking the introduction, the case summary, common causes of false non-negative THC drug test, and the pharmacology or features of CBD, the discussion, recommendation, and the conclusion. So I'm sure that most of us, we know some people that use CBD oils, gummies, or wellness products. And I'll just be clarifying the difference between CBD and THC. So CBD is the non-psychoactive substance in cannabis, while the THC is the psychoactive compound that causes the high, just like in marijuana, right? So if CBD does not cause high, why then does it show in the workplace drug testing? So in Nigeria, poor regulation means that many CBD products actually secretly contain tiny undeclared amounts of THC. So right now, I'll just be telling you a real case that happened in our facility, and this particular client or donor actually signed a consent and gave us, he signed a consent and gave us the permission to use him as a case discussion. So he is a 30-year-old procurement officer in an oil and gas company that regularly use CBD gummies for wellness. And during the routine workplace drug testing for post-offer replacement, his screening test actually returned negative for cannabis. And no medication or substance was declared, but he declared the use of CBD gummies in the medical fitness for work documentation form. Then we activated the confirmatory testing protocol, which now later showed that there was no THC metabolite. MRO interview was done, and the donor was, from the interview, we found out that the donor was not familiar with the label content of the CBD gummies. He says, that it just gives him a soothing effect. So the CBD product that he used likely contained trace THC that was just enough to flag the initial screening, but was not enough to appear in the confirmatory test. And this employee could have faced disciplinary action that could have affected his mental health and his career as well. And Substance Abuse and Mental Health Services Administration cut off for cannabis is 15 microgram per liter for over-the-counter use. So I'm talking on the common causes of false negative THC drug test. So antiretroviral drugs can cause a false non-negative drug result because of the chemical structure. The same with naproxen because it also has similar structure as well, and regular CBD use. So when you take it regularly, it accumulates as a trace THC in the test, which also causes false non-negative THC drug test. And then also hemp food products like hemp seed, that some people add it to their snacks or smoothie, or you can even see it in a granola bar as well, or contaminated supplement can also cause a false non-negative THC drug test. So the pharmacology or features of CBD, so we have different formulations. You have the full spectrum, the broad spectrum, and the CBD isolate. So for the full spectrum, it contains CBD, that's the cannabidiol, plus other cannabinoid with 0.3% THC, which is low. But broad spectrum has just CBD and other cannabinoid. There is no THC. While the CBD isolate is purely CBD, which should not cause any non-negative test results. Then CBD, unlike THC, does not produce a high, does not cause that high when you use marijuana. And then the thing about CBD is that it's discreet. It looks like regular candies. You know, when you get candies, you don't really look at the contents. You don't get to check the labeling. So you just take it without really looking at it. And then how does it work? It interacts with cannabinoid system that regulates mood, pain, and sleep. And in the US, hemp-derived CBD with 0.3% THC is legally approved for use. All right, so for the discussion, it basically just tells us that this case actually underscores the reality of CBD use among employees and a risk of false negative cannabis tests. And so employers need to be aware of the implications of CBD consumption on the workplace during workplace drug testing and how to manage the outcome. And this particular case actually highlights a regulatory and policy blind spot that creates a precarious legal and ethical landscape. Confirmatory tests and MRO interview remain relevant best practices prior to any measures, and there is need for there to be a policy reform and education of employers and employees. So what's my recommendation? So the recommendation will be: one, policy review. Does your organization drug policy clearly mention CBD? Because we have several drug policies, but does it clearly state or say anything about CBD? Because this would actually bridge the gap and discourage CBD use. And in this case, this client could have actually sued for wrongful disciplinary action, especially if there is no clear mention of CBD during the drug policy. The second would be to employee education. So most employees do not even know anything about CBD product. They don't know that CBD products actually contain THC. So, and there is a need for them to be trained. And finally, regulatory standards. Nigeria should regulate CBD/THC just as other countries do as well. And to also establish comprehensive guidelines on CBD product labeling and content testing. So in conclusion, what I will say is that as CBD use grow in Nigeria, will our workplace actually keep up or leave innocent employees at risk? So drug policies must be fair, it must be science-based and protective of employee well-being, not punitive or outdated. Thank you very much for your time and for listening.
All right, so that's it for the fourth and final presentation. However, we want to tweak the program a little bit. We're trying to see if we can have the next presentation right about now. Occupational and environmental hazards and prostate cancer, evidence and best OH practices. It's a large team. Ayodeji, Jetunde, Munyoluwa, Kimumi, James Alabi, Clement Awe, Janet Janet. Is there any representative of that team in the room? All right, please. A round of applause for her. Thank you very much. So we'll just have that presentation right about now, because when we go on the break and have lunch, it will just be this final presentation. So yes, it's coming from the back. So really there's no need to extend it unnecessarily. So we'll have paper 11, after which we'll have the Q&A session. Thank you. All right, so we have Dr. Munyoluwa Akinwumi on stage, who will be making that presentation on behalf of this 9-people team.
Good morning, everybody. Distinguished physicians, colleagues, members of this prestigious organization. My name is Munyoluwa Akinwumi. I'm a doctor, and I'm presenting on behalf of Saving Our Men Research Institute in collaboration with Saving Our Men Initiative. Unlike everybody that has been speaking, this is an NGO, not a clinical presentation. So it's today I'll be discussing Saving Our Men. So today I'll be discussing occupational and environmental hazards and prostate cancer, evidence and best OEH practices. This topic is essential because in Nigeria, prostate cancer is the leading cancer among men, which is curable. But it's so unfortunate that people present at a very late stage. That is the reason why Saving Our Men took the responsibility to speaking on behalf of men and, doing researches and advocating for men, doing screenings, advocating on behalf of men. Our evidence continues to show that prostate cancer isn't only genetic or age-related. Occupation and environmental factors contribute significantly to risk, especially in low and middle-income countries where regulations and PPE adherence may be limited. Many workers are exposed to chemicals, pesticides, fumes, night-long shifts, doctors, which can influence PSA levels and predispose them to developing prostate cancer in future. Our goal is very simple. We aim to identify high-risk individuals and apply OEH strategies that can protect Nigerian workers. The objective of these studies we are to summarize verified occupational and environmental hazards that is linked to elevated PSA or prostate cancer. Highlight evidence-based OEH preventive measures that organizations and policymakers can immediately adopt. The methods we adopted while doing this study are peer-reviewed meta-analysis, systematic reviews, large cohort studies, relevant occupational and environmental health guidance. Then we extracted exposures with the strongest evidence and compiled practical preventive strategies that are aligned with the global OEH standards. I'm not an occupational specialist, but I remember reading something about 150, C150, C178. So I know that my teachers, I've seen some of my teachers from UCH. I finished from Ibadan. So I've seen them. I know they'll be able to teach me and correct me if I make any mistakes. Thank you. So these are our findings. We noticed that in one of the meta-analysis, our findings shows that they were consistently linked cadmium exposure with increased cadmium exposure with increased prostate cancer. The companies that usually expose, the companies with high risk include battery manufacturers, weddings, e-waste, that's electronic waste companies, smelting, and some studies even show, some studies even shows that higher odds of aggressive disease is linked with long-term exposure to this metal. We all know that this is an heavy metal, and long-term exposure to this can predispose us to a lot of cancer, lung cancer, prostate cancer, and kidney diseases. Other elements include, other evidence that we saw were pesticide and endocrine disruptors. So, pesticides are usually used by the agriculturists, especially in fumigation, landscaping experience, and this was found to be modest, but it is consistently related to increased prostate cancer risk. Endocrine disruptors like BPA, that's bisphenol A, that it is common among bottle companies, water bottle companies, and most of us, we buy food, we order food, we microwave, and just do that without putting in ceramics or this, we just microwave directly. Our plastic bottles are rich in BPA. So just an information for us to be more careful of what we do, our lifestyles. Receipts, those are the, when you go on shopping, you print out receipts, and these things are risk factors for prostate cancer eventually in life. And there are some medical devices, electronics and resin products that can predispose men to having prostate cancer. I'm sorry for saying us because I'm a woman. So other are diesel exhaust, PAH, and night shifts, long night shifts. I looked at myself. I'm happy that I'm not a man because I will be guilty. I do almost 24 hours alternate days. So it's for the men here that are always working, surgeries everywhere, being productive in their work. I just want us to take responsibility of our health. Workers with chronic inhalation of combustion products, these are the firefighters, drivers, mechanics. They show high risk in developing prostate cancer. People that work, a lot of us, some of us, not a lot of us, some of us, take walk in the evenings, and, there are a lot of cars in the street of Lagos, fumes coming out of the cars, exhaust pipes. I mean, these are ways we get exposed. What of people that are walking on the street that are hawkers or people that don't even have a car to survive? So these are things that predispose them to having prostate cancer in their life. Okay, these are the solutions that we found. Using the hierarchy of control, we believe that this is evidence-based preventive measures. Number one, which I always advocate. If you can eliminate, try as much as possible to eliminate. But if it is not possible, try and substitute. This is me saying, if you know that cadmium is necessary, but there are substitutes, there are things that you can use to replace that, then get those and use instead. Especially for these people. Our men are the ones that are usually exposed. Women are not that concentrated in the production. They are usually at the execution or the distribution or the administrative part. So men, I want us to take more responsibility of ourselves. Engineering controls, that's, okay, so it's when you have proper ventilation, enclosed systems, then filtrations. Administrative control, to doctors, who you definitely have to work, I know, but we can actually, modify our shift. Instead of you doing 24 hours alternate days in a month, try and stagger it. Be kind to yourself. PPE use, protective, that's personal protective equipment. You need to take care of yourself, be responsible, N95. If there are helmets, anything you need to use to protect yourself, please kindly do that. Exposure and bowel monitoring. I know that when I was rotating through radiotherapy while I was in school, I know there's a marker that they put on, they use to read exposure. So please take responsibility for yourself. If you see that it's going beyond what it is expected, I think it's even automatic. If it is going towards that, they will cut you off and they will just tell you to go on leave. So please, let's take responsibility. That's not the time for you to keep the monitor at home and tell yourself that you have immunity against all these diseases. Please let us be responsible. Workers training. I think this is more essential for us. We need to speak more. We need to talk about cancers. We need to speak about hazards that are related to occupational hazards. And we need to use PPEs, then early symptoms. If you see something that is that is pointing towards oncology, chronic cough, your peeing blood, you are seeing all sorts of things that can point you to oncology, emergency, or any malignancy. Please speak up, seek for help. Seek for help. I know doctors are poor when it comes to seeking for help, but please take responsibility for yourself. So these strategies are cost-effective and practical, even in resource-limited settings. Medical surveillance. We hope that there will be targeted screening for high-risk workers. I know that in some facilities, they usually would screen their workers yearly. They go for medical checks yearly. So these are ways for us to do early detection. PSA testing protocols for exposed populations. I think for Shell, they now do yearly body checks. These are to catch cases early rather than when it's become advanced or when it becomes really problematic that they cannot be cured. Incorporate OEH exposure history into men's health assessment. And in conclusion, strong evidence link cadmium, pesticide, PAH, diesel exhaust, endocrine disruptors, and night shift workers to prostate cancer. Effective prevention requires multi-level OH strategies. Those are the hierarchy that I discussed, plus targeted medical surveillance. Integrating these into workplace policies visible, protective, and reduce modifiable risk factor. So this is a take-home for everybody. I want us to take responsibility of our health. Thank you.
All right. It was refreshing listening to a woman advocating for the saving of men. So, men, big ups. You are very important, right? Thank you very much, Dr. Munyolua Akinwe. Please take your seat in front. All right, we'll move straight to the panel session. I would like to invite once again Dr. Okun. So all of our speakers from the fourth presentation up until now, please, we have seats for you in front. Come and have your seats in front. Yes, warm seats.
Warm seats, they're not hot.
All right. Okay, I think.
All right, I'm not going to go through all the studies so we can optimize the time. We have our 5 panelists who are here. And so please, so that we can get as many people in, let's make the questions brief and the responses brief in a similar fashion. We'll take all the questions, you note them down, and then we answer, and then we may follow up if necessary. So let me come to this table I inadvertently ignored the last time. Any question from this table? No. All right. You, one? Okay, please.
Thank you. Good morning. Yes, still morning. Good afternoon. Thank you for the presentation. I think it's very bold to come here and present papers. So please don't mind my asking question. My question goes to the person who did a paper on the exposure to quarry dusts. My wonder is, did you consider doing a control population for your study? Because the fact that these people are living in an area where there is a quarry activity going on may not necessarily answer all those findings that you had. So it would have been good, I know, because it was probably a personal sponsor study. It may have been constrained by resources. Because I know that I worked in Edo Agris for about 18 years, so I know that some of those quarry activity are not permanent fixtures. They are seasonal in nature. And did you ask what economic benefits that the community derive from the activity of these companies? And like my head was saying here, some of these companies predate those settlements. So the quarries are actually sited out of town when they started, but because of what we call, what's that community we call them? Like when we do seismic in those days, you site your seismic camp in very far locations, but there are people who migrate because they follow the money, so to say, because most of this quarry or this kind of businesses they pay cash out of. There's no bank around that place. So then when we were in seismic in the late 90s, early 2000, we pay something like 150 million every month. So the people who have wares to sell including any kind of well you can imagine. They come alongside. So a community that has been living peacefully, the quarry comes along, and these people come and join in that environment. So it's a question of who came first. So what the authorities may have found to be a public or remote location where the control needs would not have been so stringent, for instance, requiring them to reduce their emission because it's considered a local, a remote location. The population migration that follows them now makes it the kind of situation we have. Thank you.
All right, thank you. So let me take on the advantage of the mic. Follow up on what he said. I noticed your indoor readings were higher than your outdoor readings. This is very, very different from what, because I was in the Port Harcourt air quality monitoring group. We found almost 3, 4, 5, 8 times lower levels indoors than outdoors, which strongly suspects confounders in your particulate matter. So you may want to take that on. Yeah, so I'm not going to preempt it. All right, yes,
All right,
ma'am.
thank you. Well done to all the presenters. I have 2 questions. The first would be for Dr. Madubike. Perceived lower risk of addiction to THC. I see the reason why you focused on THC, but I was curious about those who tested positive for just cocaine. I know your population is an employed population, so they probably are well paid, and they're in oil and gas. They're probably well paid, and they probably have the means of purchasing these drugs. So what happens with those people? It's a big menace in the society, the use of cocaine. So I just was curious about that. What happens when you find them positive to just cocaine? What steps are taken? It may not be part of that study, but just curious, like I said. And then the second question to Dr. Mba Medbury. The Google Sheets tool you referred to, I'm not quite sure what the components of that tool were. I don't know that you showed them. And then considering that you were working with bakeries, did you take into account the educational status of the workers and how they could use that tool and not just use it but sustain it? So those are my questions. Thanks.
All right, thank you. Sorry, I must add, it's very nice to have the mic. Because you said positive, but I noticed you said you did not use the confirmatory tests, just the screening tests. And in my experience, and I'm an MRO, a lot of the tests that come out positive or non-negative, as we say on screening, end up not being positive, especially when they've been on chloramphenicol. Sorry, what was it? Ciprofloxacin. So that was a big one that we had. And the case that was just presented about CBDs. So I'm a bit curious as to why you chose not to look at confirmed cases. It would be interesting. Yes, doctor.
Thank you very much again. Speaking on the work on prostate cancer, well done on the presentation. Just to ask, you talked about the risk with the farmers being the ones that actually use the pesticides. But what is the risk of prostate cancer on the end users that eat the crops? What is it? I know it causes cancer, but is there any direct link to prostate cancer specifically? Also, you talked about the risk of fumes to prostate cancer for those outdoors. Very interesting. But what is really the percentage probability of getting prostate cancer by being outdoors? Because I'm really concerned. In River State, we had a lot of, exogenous fumes going on. So I just want to know whether or not my risk has gone up, including my age, of course.
All right, so
thank you to all the presenters. My own question goes to Dr. Uba on the accessible hazard reporting tool. My question is similar to hers because I was curious as to, because of the category of workers you used as your respondents, did you confirm all of them have access to smartphones? And was it the responses or the use of the tool during the study period, was it through a proxy, maybe the manager, or did all respondents have access? I don't know if I missed that part. Okay, through the researcher, okay. But then subsequently, going forward, if we do decide to deploy the tool, how then would they have access to reporting? Is that something you've also factored in? And then for occupational environmental hazards linked to prostate cancer, I don't know, some of us here from Kaduna, there's something that is rampant that I observed that I actually reported, but I'm not sure anything was done about. So maybe when we go back, we can zoom in. The use of tires for roasting meat, slaughtered cows, slaughtered goats. Yeah.
All right, thank you. So I have two questions as well. The first is for Sims. This one is just for further information. The quantitative analysis of the THC of the donor, do we have the particular figure? Because it wasn't mentioned. We only know that below 15 or below 15 micrograms per liter is legal. Then the second question is for our colleague in the NGO with the prostate and occupational and environmental health risks. You highlighted quite a bit on elevated PSA levels. So is the risk only for prostate cancer or other prostatic issues? You know, because, you know, elevated prostate level, elevated PSA levels are only just a sign. It's not the end game. The end game is what we're looking at, which could either be any of the prostatic diseases. Thank you.
Good morning. My question goes to the presenter from ERA. Sorry, I don't remember your name. Wonderful study. But I'm just thinking that, you know, so you have a lot of recommendations, policies for the government and all of that, but we know those things take time. And we also know that those people will not relocate because it takes money, you know, resources to relocate, which they do not have. But in the next 10, 15 years, many of them will come down with lung diseases that they will also not be able to afford the treatment for, and they may die prematurely. So what did you tell them? What measures did you put in? Did you ask them, or did you teach or train them to put in place as primary preventative measures that they can do themselves? Do you understand the question? So not government now, but personal. Thank you.
1, 2, 3, and then we move there. If there's some more time.
Okay, good afternoon. My question goes to the study on the quarry. Sir, I don't know whether when you did your study you considered ESG. You do consider anything about ESG? Okay. Secondly, and I want to know, I don't know whether you know what is ESG, because I feel for such study you would have needed an ESG expert, you know, to perhaps work to collaborate with you, you know, because they do more of environmental metrics, like they do all those field work, all those environmental, there are things they do that might be beyond you, you know. So ESG from my knowledge and based on my experience, because we are one of the consultants that work at AMC, these are Abuja, the hospital in Abuja, and what those clients did is that they brought in. We were the HSC consultant, and they brought in an ESG consultant. So my company was what? So ESG, it means environmental, social, and governance. You understand? And what they do is that they come up with a framework that is used to align a company's operation, you know, in respect to managing risks and, you know, foster safety culture. But they do more of the, you know, all those communities where you're doing your own project. ESG guys are those that are supposed to be interfacing directly with them in respect to environmental issues. So now this is my question now. What framework do you think, and I don't know how you answer this question because you understand much about ESG. What framework? I feel there's a possibility of a collaboration between ESG and occupational health, so that they do more of the field work for you, and it's easier for you to be able to integrate their data into what you want to achieve for the organization. So I feel for most studies, ESG can help in that area to make your work easier. Thank you.
All right, thank you. 1, 2, and then Prof. 3, I believe.
All right, thank you very much. Mine is a very simple question, and it's to Dr. Madubuike, right? I just want to find out, the THC, was it, there are different forms now. You see the one they call loud. When the questions were asked, was that put into consideration? The synthetic and the natural one, whether they were put into consideration when the questions were asked. And also, the route of administration. There's also, I've seen some people who administer THC via IV route. They'll boil it and then inject it into through their vein. So I don't know if you consider that while you were doing your study.
Good afternoon, everybody. So is a comment and a question. For most of the presentations, some of the people who had tools, it would have been nice to have added a slide that had a copy of your tool as probably an addendum. So we have an idea of what was asked. Then the question I want to ask is for the substance abuse. Ma'am, Madubuike, yeah, okay. So you conveniently picked a convenient sampling technique. Do you want to shed a little bit of light on why you picked the oil and gas? Because you can do that, is agreed, but we want to know the rationale behind it. And we also want to know that when you're extrapolating to the general population, that your conclusions are basically focused on the oil and gas. Thank you.
Thank you. My question, the first one will go to Dr. Madubuike, as related to drug and alcohol testing. In the course of your presentation, you clearly mentioned how you go about handling benzos when they are positive. So what do you do when opioids are positive? Because opioids is still a component of that drug test kit. You have some people, they work on site and then they are on prescribed opioid analgesics. You do the test for them and then it's positive. So how do you handle such situation? You don't know what particularly they are taking, but in the opioid family. That's one. And then the second one is where somebody touched something close to that for you on the query site. Fantastic presentation. But if you look at it, you made recommendations. Are these things just, you make them the recommendation and then you sweep them under the carpet? What happens next? Because we know the effect of this thing and it's happening. We are seeing them. But we have studies to show that this is coming from here. So what are we doing to further the result of this your studies? Thank you.
So 2 more.
Thank you for all those presentations. Wonderful. I have many questions, but Dr. Kunz has restricted me to just one. So let me just take one question, or maybe two, 1.5. The retrospective cohort, did you have concurrent or historical controls? And if you did not have any control, why didn't you have any control? Then the trend, something about trend. You didn't do a trend analysis. You didn't show the graphs. So I have many more questions, but all in all, I'm very happy with the presentations I saw today.
Excellent, and thank you. I think there will be lots of conversations with the panelists beyond this session. There are many more questions that are burning.
Thank you very much. I want to say thank you to all the speakers. The presentations were very interesting. I have a few points, just not very many. That presented for the small-scale industry, went into the details of inclusion criteria and exclusion criteria. I want to just say that criteria is what makes you include the person in your study. The exclusion criteria is what makes you exclude him after he has fitted the inclusion criteria. So if you say inclusion criteria is 18 years, then exclusion criteria is if you're 18 years but you don't meet the description for the criteria for some other reasons, either you're sick or you're something. But it is not being 18 years. I always have to do that in many situations, that we know the difference between exclusion. So exclusion criteria is not the opposite of inclusion criteria. So that's one point. Sorry, that's a teaching point. Okay. Then I wondered why had said pre and post, and I said, what was your intervention? Just put it in the Google Forms was the intervention. So you had pre, and what did you do pre? What were the variables you studied pre? You had a bit of attrition to the study, and I think you should have explained why the numbers became fewer and fewer. 40% of them had OHS policies. I'm quite surprised at that. You cite them. That's my question on that. So, and then the person for the drug abuse, I think Dr. Ada has addressed this. You have compare them with the local population, because before you can say oil and gas people need to be doing this and this and this and this, it's a situation that does not affect the local population and just affects the oil and gas people alone. Thank you very much.
Thank you, Prof. So I will start, before I start from the right side, I'll start from the left side now.
Thank you very much for questions and your contributions. It was quite enlightening too, as well. Okay, so taking the question that speaks to the educational status of the respondents, what we found was that the educational status did not impact their ability to use the tools. And it's not too difficult to understand. There are a lot of individuals who are not that educated who play around a lot with smartphones and things like that. But specifically with respect to this research, we had research assistants that also assisted them to access the reporting tool. And of course, once they had helped them a couple of times, then subsequently it is expected that they would know how to go about it and use it. And so educational status wasn't a challenge. In fact, what our study showed was about 95% of them had no issue using the tool. So I think educational status wasn't a problem to look at. Then in terms of deployment of the tool, I think partly the question is also answered by the fact that quite a number of people carry smartphones, but we also figured that there could be the shared, people could also use other people's phones, so it didn't have to be their own phones necessarily. The major tool that we consider was smartphones. So for instance, if they had colleagues or they had senior people who also had smartphones, they could access the tool through their own smartphones. So that wasn't going to be a barrier ultimately. So it didn't have to be that they must necessarily own a smartphone for them to be able to deploy the tool. What was the other question? Then the company. Okay, the percentage of, yes, 40% had OH policy.
some thank you. They had some arrangements in place. Some of them were very undeveloped, as we will all understand. But they had some arrangements in place. Yeah, so in the same vein, when we talked about training, the training could be as simple as, are you aware that this thing can cause harm? Did somebody show you this? It's a very, very rudimentary type and basic type of things, not something as organized as all of us are, familiar with, versus if they knew nothing at all about it.
There was a question about attrition. Yes.
Yes, the attrition observed is a very is a very genuine observation, and you would see that you started at 120 something at the start, then it started to wither down until you got to 40 something in the post intervention. Why that happened wasn't tested, but we can only assume that it was either they were busy, they couldn't sustain attention on feeling that we could assume, this is not subject to any test. It could also be that they got busy, and they couldn't do that, or something, because the research assistants did not always stay with them throughout the 6-week period. So we don't know, that's the honest truth, but indeed it's something that punctures a hole in the entire study itself. Or they didn't like what they were saying, or they were worried that we were using. In fact, somebody said, "Are you from government? Will you report us?" So that also probably played into it.
Thank you so much for your questions. The first question was the relationship between pesticide and end users. Those are the consumers. So there's no strong findings on the end users. We need to understand that the amount you are exposed, we cannot stop fertilizers or chemicals from being used. So the amounts you are exposed to can really not be quantified. So that really did, all the papers we checked, there was weak and inconsistent values for that. The second one is percentage of PSA, rise PSA in outsiders, people that are on the streets walking and doing their exercise. So another thing that is important is the number of exposures, the intensity, the years, and other risk factors. We know there is always genetic factors. There's modifiable, non-modifiable. The modifiables are the ones that you can control. Non-modifiables are the genetic and other ones. So there's really there's no specific percentage, like 2% of this, we predispose them to this. It's just a risk for developing it. The next one is use of tires in risk of tires for smoke meals and the likes. For that, there was a study done in Ghana that shows that the meats that are dried by tires are actually reaching polycyclic aromatic. So that is a risk factor for developing prostate cancer because it's a chemical. Okay, the last one is this risk? Okay, that is a risk only for prostate cancer or other prostatic disease. No. It's both for prostatic and prostate cancer. It's not only specific for prostate cancer, BPH and other prostatic diseases. Thank you.
Okay, so the first question was on cocaine. The people who tested positive to cocaine. So that's, considering the cost of cocaine and all that. The funny thing is the personnel who had tested positive to cocaine were experts, and they had their plugs within the company, people who supplied it to them. And when during the MRO interview, it was obvious that they had abused the drugs, and the results were communicated to their, to the company through the established routes. Of course, for all the results, you would always indicate that these are screening tests. So they are always subject to confirmation. And then you asked why we didn't use the confirmatory test result. Firstly, is that sample size was small. A lot of the personnel, when they test positive, during the MRO interview, a lot would admit. Now, for those who do not admit, you would also tell them they have every right to contest the result, and the company ought to send the test sample out for confirmation, and the company has a legal body to pay for, or the ethical body to pay for it. But from experience, a lot of times they do not take that route. So getting the confirmatory test results, the sample size for that was very small, so we had to exclude it from the study so that it would just be only the screening test results to form just the baseline. Okay, and then you also asked about tests. Okay, so also on the confirmatory test, I think it's basic rudimentary now for MROs. What MROs do basically is to just find out if there are alternative explanations for a positive test result. So somebody tests positive, like I think you used them, like tetracycline or something. There was a drug. If somebody tests ciprofloxacin, sorry. So if somebody tests positive for any drug, the first thing an MRO does is you want to know the list of drugs, medications that the person is on, and you want to know if those medications could cause a false positive. For every medication, every drug, there are lists of possible drugs that could cause it. And even the list keeps evolving as, things happen. The list keeps, increasing. So that's the basic. For every test result that came out, the MRO did the interview and needed to find out what medications has the person been on, and could that medication probably cause a false non-negative. So that was done. Okay, so anyone that didn't have a reasonable explanation, alternative explanation, was regarded as a verified non-negative. Okay, so did we capture the synthetic, whether it's synthetic or natural? We did, but it wasn't for everybody, so we had to remove it from the study. So some would tell you, yes, they took, like I said, they took brownies or they took it in pepper soup. Some others will say, okay, yes, it was loud, or what's this one now, the colos. But usually, for most of them, they will just tell you that they smoke marijuana. So we didn't get that detail for everybody, so there was no point including it. And the IV route, well, that's news to me. None of the respondents admitted to taking it via IV. So, that's something new. Okay, so someone asked why we conveniently picked the oil and gas population. So remember that the objective of this study was to do a trend, to compare year by year, rates. It wasn't just to know the prevalence, but also to compare. So that data was easily accessible from 2021. We couldn't access data for, even other industries from previous years. So it was easily accessible data that we could use. And also the rationale for the study was to know if, like someone asked about historical samples. The rationale for the study was to know if the trend had been increasing. Industry. It was to just know if the trend had been increasing, like it's publicly acknowledged that the trend is increasing. So we just wanted to use that subset as a sample population to just check, and we saw that it wasn't increasing in that subset. But of course there are limitations, so you can't just juxtapose this population onto the general populace. Okay. Opiates. Okay, so opiates. So usually for opiates, you still do your regular MRO, but opiates verification is a bit tricky because now you're looking at the level. You're now doing a quantitative analysis. So beyond a certain positive and non-negative, below a certain quantity, then you would now have to check. Okay, so is the person abusing that, like drugs, maybe for somebody else, a prescription is tricky. But for the purposes of our study, we just looked at if the person has a prescription, that's verified non-negative. If you didn't have a prescription for the drug, and then there was no other drug that could have possibly account for the positive test, then that was regarded as, like a non-negative test. So that's it, the historical control. We showed graphs and pie charts. I don't know what other graphs that you refer to. Someone said we didn't show graphs. Well, not graphs, but we showed the pie charts and the bar charts. Oh, okay, trend. Oh, okay. All right, so that wasn't noted. So that's noted. Okay. All right, so that's it. So local population comparison, like I said before, it's accessibility to data that was a limitation. We can't access data for the local population over 4 years. Thank you.
Thank you very much, Dr. Kenneth. CBD as an index case. It was the first time I was hearing CBD. I've heard all sorts when people test non-negative to THC. I've heard, when I was coming this morning, I ate pepper soup cooked by a man. So hearing CBD, picking it incidentally, and to tell you that it was even innocent, was the fact that in the drug and alcohol testing form where you declare what you use, he didn't. It was during MRO interview, incidentally, I happened to be the one reviewing his medical fitness. I picked it under medication declaration or what you're taking, supplements. I picked it from there. I transferred it into my judgment. So it brought to my knowledge thinking how many people who supposedly have been non-negative, whose company policy did not support confirmatory tests, were innocent. And I also started thinking about all the non-negatives that became negative in confirmatory tests. What is the modality? What am I trying to arrive at? The confirmatory lab use liquid chromatography mass spectrometry. When we asked them what do they mean by undetected, the confirmatory result was actually undetected. They explained that undetected does not mean there's no trace amount. It's only meant that it was below the detection limit of their own machine. And I asked myself one more question. Because this is the first case we found, do we have an established pattern of the stability of trace amounts of THC in this substance between the period of collection and the period of confirmation? So when we have subsequent CBD non-negatives, we'll be able to establish, are they always undetected? Do they, what is their stability pattern in the urine? So I hope that answers your question.
Thank you very much. I'm happy at the feedback presentation has drawn, but I need to make quick disclosures. First, that it was on behalf of Abba, Ediawe, and Abba. Second, because Professor Abba had to travel, and I worked in Europe for 3 years, so I understand the setting, and I also understand all the authors. And it was in fulfillment of getting a fellowship of the West African College of Physicians in community medicine by the second author. Now, to answer the questions, the scope of this study was largely descriptive. Yes, it was better there was the control, but as it is, what was used in this study from the materials I also saw was the WHO standards for PM 2.5 and PM 10. But I will cascade it and inform them on this for subsequent research. Now, with regards to which came first, because one of the participants asked, particularly based on experience in the query area, that experiences there are seasonal. Historically, did the query that came first or the people that moved there? It's something that one will still have to investigate and ask them over there. Then it was striking that the indoor readings were higher than the outdoor. It was quite an observation, but you will notice that in the slide, observations were made for cooking gases, ventilation, and housing. Would it be attempts to sweep and all that, or what they use as fuel? I can't say, but I'm going to take this observation back. And then with regards to the ESG, remember it was self-funded, so there was a limitation on how much could be done. However, it's something that, as has been said, if it's done as a project, should be included. Very importantly, what are we doing to further the results of this study? Presenting in this conference and getting this feedback is part of it. It will be published, and it should help to guide a policy brief if it has to come to that. Now, for this issue, it really hits at the level of primordial. Because if we recommend that because of their proximity to the query sites, they start wearing face masks like post-COVID-19, knowing the social status of people that live around there, it might not be sustainable. But with my understanding of how we do research over there, particularly with the Lassa Fever Institute, anytime we go to a community, at the end of it, there's almost like a town hall where we give back, just health awareness. But I will give them a feedback so that something sustainable can be done. Not that years after, people are coming down with these lung diseases just because they lived in that area. Then somebody asked with regards to tool. With the permission of the authors, if you need the tools that were used, I will send them across. But largely, thank you for your time.
Thank you, but I cannot resist the urge to throw a question for all of us, especially as we have two presentations on drug use. No. If you go around the world today, and I beg you to Google, CBD and even THC is becoming legal in most places. I think the interesting question would have been, are we seeing an increase in workplace incidents, etc., as the use of these drugs seem to be increasing in the workplace? That would be informative. But more importantly, with the ready access to CBD, vapes, supplements and all, what are we doing in our own current processes to determine what importance we give CBD detection in our workplace testing? But longer term, are we going to shift with where the world is going? Are we going to go against where the world is going? Or are we just going to let things happen and be scattered about it? I think there's something we really need to think about, but we cannot pretend we don't know. In most countries today, CBD, THC is legal. Although I must state that in America, the federal system doesn't accept it, but many states accept it. Thank you very much. Same in Canada. And some don't. Yeah. So what I'm simply saying is it's coming, so we need to think about it. And because of the ready access, we should, of course, automatically expect that a lot of our wealthy oil and gas, etc., who travel a lot, will have access. So we really need to think about what we are bringing in as policies and what we're going to do, and how we're going to educate on this. Lovely panel, thank you very much. We enjoyed this. The room enjoyed this. I believe we are now going to the panel's poster session. I can see we have a poster there, we have a poster there. And in light of the feedback we got yesterday, we just don't want to be sitting. So going to the posters and interacting with the authors is an excellent way for us to stop smoking. You know what I mean by that? Sitting is the new. Thank you.
All right, thank you very much, Dr. Okuns. Thank you very much. Just before we have the part of the poster sessions, please listen to the following announcements. Thank you very much, our panelists. Thank you. Please listen to the following announcements. We have a lost but found pair of glasses. So if that pair of glasses belongs to you, please visit the registration desk. I'll say that again. Lost but found pair of glasses. So if you are missing your pair of glasses, please go to the registration desk. Thank you very much. There's also a device, lost but found, all right? I don't exactly know what the device is used for, but from what I can see, it appears that it pairs with phones. So if you are missing that device, Probably you attended the dinner yesterday. So if you are missing that device, please come to me. All right, this is also very important for all those who registered before the 31st of October. Please visit the registration desk to pick up your bags. All right, if you registered for this conference before the 31st of October, please visit the registration desk to collect your bags. Then for those of you who registered for this year's conference and you're yet to pick up your receipts, please also visit the registration desk. For those of you who attended last year's events and for one reason or the other you've not collected your certificates of participation, those certificates are also available at the registration desk. All right, so that is all we have in terms of announcements. We'll move straight to the poster presentations, and that will happen for the next 30 minutes, 15 minutes per presentation. So we're going to divide the hall into two groups. This is the first poster. There's also another poster at the end of the hall. So first row, those who are sitting in the first row, please proceed to that poster. Then the two tables behind the first row, two tables on the second row, please, first poster. All right, so first four tables in the first row, two tables in the second row, please proceed to the first poster. Then from this table and the rest of the hall, please, that will be your poster. So let's do that very quickly, very quickly. Thank you very much. First six tables, this poster, that table and the rest of the hall, the poster at the back. So we'll do this for 15 minutes per poster. So at the end of 15 minutes, we'll switch. All right, so the poster presenters, please go to your poster very quickly. We have one in front. There's another at the back. First four tables here, please come to this side. The next two tables in the second row, please come to this side. This table and the rest of the hall, please go to that poster over there. We have 15 minutes each, please. Once it is, yes, over there. So we have 15 minutes to make the switch. So it is 12:52 right about now. So by 1:13, we'll make the switch. So we'll just move from here to there, and those on the other side will also move here. So let's do that very quickly. 15 minutes per poster presentation. Thank you. After that will be lunch, and after that we'll have
Hello.
What's with the feedback sound?
And operational well-being. So this study, okay. So the study was conducted in 2024. We had some persons coming during the annual medical, the regular annual medical. Now, out of 1,400 persons, we had 1,000
132 persons completely and correctly they had to. And then we used that as the major tool. Meanwhile, we had collected other demographic parameters as well. You can see the table below, we had collected their clinical history, aside from the normal biometrics where we had to calculate BMI. And then part of the biometrics we took were part of the history we took were clinical history of chronic illness. We had now, the study was a cross-sectional analytical study, and then the tool we used, alongside collecting all the other clinical details, the tools is a HART tool, which is a hospital anxiety and depression scale. Now, describing it, it's a tool used to assess mental health symptoms. Okay. Who should move away from it? Okay. I won't see properly. Okay, so the tool.
But the mic will not allow us to communicate.
Okay. All right.
So now this is to us.
All right. So the tool is being used outside of psychiatric hospital setting, other clinical settings outside of the psychiatric hospital setting, used to assess psychological symptoms. Now the tool contains 14 elements, 7 each for the major mental health issues, which is anxiety and then depression. 7 elements goes for anxiety, 7 elements goes for depression. And then the 7 elements, each of those elements are scored 0 to 3. So in all, you have a total score of 21 for each of the 2 symptoms, which is anxiety and then depression. Now, it's being graded, each is being graded into normal, borderline, as well as significant symptomology. Now, when we have 0 to 7, a lot of times those are normal individuals, and then between 8 and 10, we have people who are in the borderline. Above that, that's 11 and beyond, persons who have that score have significant symptomology for both anxiety and depression. So that was the tool alongside other clinical parameters that we took, like I described earlier. Now, we assessed this as 10 data sets. Now, looking at the table below, we have said the 10 data sets inclusive of the gender, which is male and female, who makes 2, health-related issues, there were 3 of them, hypertension, diabetes, as well as obesity, makes 5. Then the age, persons under or equal to 40, and persons above 40. And then the work locations, persons who worked onshore and persons who worked offshore. Now, we assessed the main differences between anxiety and then depression using the Pearson test, while the correlations in between them was we used Pearson correlation score to do that. Now, the key findings will surprise you. Some will surprise you, really. Now, anxiety for World Health Record, most of WHO record is often the most having the highest, having the higher prevalence than depression. It happened with us same way. Anxiety came higher than depression was. And then in all of those data sets, anxiety, like I said, was more than depression in all of the data sets. Now, the prevalence we found for anxiety and depression were lower than the WHO prevalences, as well as so many other studies. We had lower prevalence. Some of the reasons for this would be, well, I'll say a pre-selection for a healthy workforce. This, like we said, is an oil and gas company where we have, regular occupational health support, and it's a stable work environment. So it's easier to have persons within that company having a good psychological climate for them to have had this low prevalence. So the prevalence is lower than most of the studies other studies in Nigeria. Some other studies we compared with that carried out within the general public as well as within a certain clinical settings. What we had was lower. Now for anxiety, significant symptoms, we had a prevalence of 2.5%. For depression, we had
1.4%, as compared to the WHO. WHO anxiety had about 4.4, while depression had 4%. Now, to surprise you, the borderline cases were actually much more. Now, we said significance is 11 and above, but the borderline, that's 8 to 10, were actually a lot more. Now, what borderline means that you can't really ascertain, you can't call that being diagnostic, but you can't really ascertain if it's what the level of significance symptomology is in the patient, meaning that their borderline, the level of impact it's having of them is not as significant as those with 11 and above. Also, like I said earlier, anxiety across all the data sets was higher, that's the prevalence, than depression. And then for the females, we found out that females were 3 times more likely to report symptoms than the male. That was another major finding. It's in accordance to most findings. I would say, well, due to the double burden on the females, the home front as well as being professional. So that dual burden oftentimes could tilt females into, reporting the symptoms more than the cultural and occupational as well, who be the ones predisposing women to having that. Surprisingly, employees under 40 also had higher prevalence than those 40 and above. Well, when we try to decipher what the cause of that could be, we found that, well, they're the younger ones. One, that's the age in which they're trying to build life. There's a work strain. You're trying to build your professional level. So at that point in time, a lot is often expected of persons at that age, which could increase their stresses rather than persons above who probably are well established, the high hierarchy of, high control when it comes to management and then what is required of them at their work points. And then surprisingly as well, one would normally have thought that offshore persons would be under more stress or psychological stress. But the study, our results, we found otherwise. We found out that onshore personnel actually reported more symptoms than the offshore personnel. And we tried to find out what this is. Most often, offshore personnel, when they're there, they're catered for. Everything is within their reach. Their family issues are far away from them. They're dedicated to their work, and then less stress. That practically everything, they don't have to worry about food, the only thing probably they may have to worry about is, well, the fact that the environment, sort of a restricted environment, yeah. But then persons outside of town, you need to worry about security. We all know what's happening these days. Not just security, they're in close proximity to family members, a whole lot of problems, that they have to deal with, traffic as well, and those kind of stressors every day. And then, of course, we all know how it is these days. Offshore, because of safety. Once you're done with your shift, you're off. You go have your rest, so that you'll be well focused when you're back on shift. But technology these days, onshore, we see most of us walking into the night, to try and meet goals. So that also could account for the reasons why persons onshore have actually more stressors. So the next table gives an eye. You can see that it displays the percentage of persons within borderline and a significant symptom. And then the graph below shows where we made a comparison of the main cause between anxiety and depression across the data sets. You will see that in all of them, the blue column, which is anxiety, obviously well above depression in each one of them. And then for chronic diseases, it was only hypertension that had, kind of a modest link with having elevated symptoms. Others barely had any impact. They had little impact. Now, the low prevalence we observed could be as a result of healthy worker effect, meaning that persons who are actually working in a well-stable environment, well-supported environment, assessing them, they're actually a lot more healthier than the general public. Now, it could also be because they are well-supported. Occupational health support, employee assistance programs, a whole lot of other within this particular company we chose, a whole lot of culture amongst them, diversion and inclusivity for, across age groups, across gender, well coordinated occupational health support and surveillance. So with all this, it cannot be perfect where they probably would have a low prevalence of such symptoms. And then for the areas we noticed, where the practical implication of all of this, where we have to improve is having gender-specific interventions, especially to the women, addressing their issues to make it better for them, and also for persons onshore, how to make bring up programs to actually ensure that they're better helped. And then for the persons for the younger ones, persons below 40, a whole lot of psychological help programs, mentorship, and a whole lot of that recommended for them. While we had a lot of, while the borderlines cases were more, we're considering shifting down a little for that company. They should bring down a little their cutoff point so that they are able to capture the larger group within that borderline to help, early detection and of course intervention, rather than have them cross over. So if I have any question regarding all of this, I'll be willing to provide more. Well, we targeted this to a particular company. Such have not been recorded within the company, but we've heard in history that that has been occurring. Now, the fact that we probably may have had cases, one in only God knows how many, does not mean the fact that even if it's just one, of course, it means it's quite significant. But within this group of persons that we studied, these were the results we found. And the recommendations is targeted towards them, for them.
There are different categories of people working offshore. Some people are educated, some are not educated. It depends on kind of, so different people have different kinds of exposure to stress. Some will be able to cope, have coping mechanisms, some don't. Some have support mechanisms, some don't have. There are different kinds of people. Yes, yes, people who have problems. Yes, you have different groups within the group.
Thank you so much. That's a take home. We intend to move forward with this research, so that we certainly be looked into and then included into this. Thank you. Okay. Of persons fall within the borderline. Okay. No. Exactly, and that was why we considered adopting a lower threshold as part of the last recommendation. So in them, prevalence was as high as 8%, and then the prevalence was as high as 3.2%. Now, these two values compared more with what the values of WHO and then some other studies, especially a Lagos study, compared more with that than the actual anxiety, people who had symptoms. So the more reason we considered moving forward downwards so that we can actually catch that group and then have them early diagnosis with intervention.
Whether they're workers or executives, that also is something we could implement. So we also use that as one of the things we compare, one of the parameters. We speculate
Okay, thank you. That's, thank you. Office based, yeah. Okay, so you're very right. Further, that is what I'm saying. So further analysis, further study now would have to include. There's more we're looking at as well. Percentage of persons willing to even have treatment. It's going back to go and analyze because while we're taking the biometrics, part of what we also capture is also job group and then also position. So we can go back and assess that and then analyze with including it. Thank you. Now, this is a multinational company, oil company, quite stable. I bet you that finance is not a problem in this area. And the occupational health as well.
Don't presume. Madam, don't presume. Yes. It is. Please don't presume. Not everybody yes. In the midst of plenty, some are less privileged. And also, madam, with your PhD, it's very, very nice that we have developed that for our environment.
All right, we need to make that switch. We need to make that switch. So those at the back of the hall, you need to move to the front. Those in front, you need to move to the back of the hall. Thank you. We need to make that switch now. Thank
To see
you.
what are they being used. In fact, the part of the surprise for us was the fact that one person's onshore experienced more, but really looking through other studies as well, the speculations were related to other things we found in other studies as well, meaning that the fact that they are readily available, the everyday stressors, like the technology improvement, like we talked about, the fact that persons onshore, because of safety and the fact that they need to be focused. Once you're done with your shift, you go here. We keep on technology. We keep on walking into the light. So work-life balance is actually poor onshore than offshore. Good afternoon. Okay, you're welcome. Yeah, so our study, okay, I am here on behalf of all the authors. I must acknowledge my senior colleagues, Dr. Chidi Obosi and Dr. Adedayo Adebise. I am Dr. Adwalawao. And then the study is assessing anxiety and depression in an oil and gas company in the Niger Delta, Nigeria, using the HAT tool. And then the links are the prevalence and then socio-demographic links that were looked into to connect the whole stuff. Now, the aim of this study was actually to assess the psychological climate within the chosen oil and gas company, and then compare within the demographics how the prevalence tends to be. Now, of the about 1,140 something persons, we had as high as 1,132% of persons who actually filled correctly the tool, and that's about 99% response rate. Now, these individuals, we had them fill the HART tool during their annual medical assessments, as well as we collected other demographics. Like we can see here, their gender and also some health-related information, data like chronic diseases, age, work location, and all of those were also collected. Now, the HERTZ tool, which was the main tool we used, is a standardized tool used to assess psychological symptoms in a non-psychiatric hospital setting. So we can use that in any other setting aside the non-psychiatric hospital setting. Now, it has 14 elements, 7 items, 7 of them assess anxiety, the other 7 assesses depression. Now, for each of those elements, the scoring system has a maximum of 3 and a minimum of 0. So in all of this course, it means that anxiety, the maximum, for each of the elements, either anxiety or depression, each of the score has a maximum of 21. Now, grouping the scores according to symptoms or significance. When we have 0 to 7, those are persons that are normal. Their scores falls within a range where we do not have to worry about what their psychological symptoms were. And then the borderline cases are persons who have scores between 8 to 10. And now for individuals that had 11 and above, those were the ones with significant symptoms. Now, we used PhD test to assess the mean though demographics is gender, we had male and female, health-related issues, diabetes, hypertension, obesity, then age, persons less than 40, and then 40 and above, and then the work location, persons who worked onshore and then offshore. Now, we use persons correlation test to actually assess what the associations between anxiety and depression were between those demographics. Now, in overall, the key findings we have was in all of these cases, all across the 10 data sets, anxiety constantly had a higher prevalence than depression. That's one. But generally, the prevalence we had were low as well, lower than the WHO rates, and then lower than most of the clinical studies we've seen. Now, those other studies did theirs within the clinical section, and some did it in the general public, but the prevalence here we had was low. Now, I'm trying to explain that it could be due to the healthy worker effect. A lot of times we have pre-selected persons working in this kind of environment because of the screening processes before you get in. And then aside that as well, we found out that for the females, they were 3 times more likely to report symptoms than the male, which that actually correlates with most of the other studies and also the WHO findings. And then we attributed that to the dual burden effect, cultural, being the chief person in the home front to bear all the issues, cultural kind of perspective to it, and also occupational, the professional part of it, having to bear the double burden. That could account for reasons why women could feel that a lot more. And then for employees under 40, surprisingly, and then not really in correlation with most of the other studies, persons under 40 tend to actually show more symptoms than persons 40 and then above. And also onshore personnel, we found out that onshore personnel reported more symptoms than the persons offshore. Now, for the age, we realized that the younger ones are the ones really aspiring. A lot of stress. That's the age group during which, they try to build their life. Ambitious, so there's work strain, there's a lot expected of them, there's a family strain on them as well. There's a lot of aspirations, and then that's the point where everybody tries to hustle and then tries to see how they attain a good standard at their job roles. So for the offshore workers, due to safety reasons, a lot of times once they are done with their shift, everybody goes to rest because you need a lot of focus. By the time you're returning back, you must be well refreshed. It's a different ballgame when you're onshore. When you're onshore, we have the traffic issues, we have security issues, we have the proximity to family, where you tend to listen to children, where you listen to family, a whole lot of that. So that may probably account for the reasons why offshore persons may have higher incidence. And like I said, across all the data sets, whether gender, whether onshore, whether offshore, whether younger or higher than younger than 40 or greater than 40, anxiety exceeded depression, the prevalence in all of them, which that actually correlates with what WHO statistics say. Yeah. So these graphs and then the bar chart, this shows us the mean scores between all some of the data sets, and then these some prevalences of what we got as well along the 10 data sets. And then regarding the chronic diseases, surprisingly, it was only hypertension that tend to have a very modest, um, association with increased anxiety. Others barely had an impact. A lot of times it is expected that, and some other studies we came across had higher prevalences of persons with chronic illnesses, having anxiety and depression. Now, what we thought may cost us is a stable environment. In this kind of setting, they are well supported. They don't have to worry about medication cost. They do not have to worry about hospital cost. They do not have to worry about seeing a specialist. Prompt surveillance. They even get diagnosed earlier, in less complications in these kind of persons than compared to the general public. So it's sort of understandable if we had just a modest association with it than the general public. Now the conclusion, well, like I said earlier, the low prevalence may be due to the healthy worker effect, where we have, where everything is stable and then they're well supported, there's good occupational support, there's employee assistance support, there's a good culture, safety culture and psychological psychological climate within. It goes just beyond. It goes just beyond the well paid. It's an atmosphere where individuals are able to speak up about anything. Yeah, exactly. All this bullying, harassing, you're able to speak up openly about all of these. And then there are trainings, continual trainings in all of this, telling people, getting them informed, a whole lot of health education, a whole lot of occupational support, a whole financial support as well, financial stability rather. So it's understandable if we had low prevalence in them like we had reported. However, we recommended, for persons that we have found to have for the data set that we have found that needs improvement, we had recommended targeted interventions, like the females, targeted interventions towards them, the younger age group, as well as the persons onshore. So a whole lot of programs to be set up to address these individual groups. And then looking into the fact that the borderline cases were actually much more than the actual incidence of the anxiety, the significant anxiety and depression. Yeah. We're thinking of, okay, if we drop down the point of, attention to just below the borderline, we're likely able to catch more persons, and then there'll be early diagnosis, and then, of course, treatment. And with that, we know that there's likely good outcomes of management, and then less complications. So.
Drive those within the borderline, bring them lower so that they leave that space and what happens.
Okay. Right now, there are a whole lot of, when we come across screening, there are employee assistance programs for which individuals can access, online, free, made available to everyone. And also walk-in clinics where we have them, have psychological therapy. Now, if we say that, of course, this is just, psych therapy is just different from actual medications, different from therapeutic, having to use medication. So all those are in place for them. Reason we're trying to even drive it down so that we catch more persons. But part of what I would love us to do further on this, because it's a different thing to get diagnosed, it's a different thing to come to terms and accept treatment. What I would have loved is that we go further and then assess what percentage of these individuals are actually willing to be managed. Because, like we said, this is addressing mental health issues. Stigma is one of the issues that people, a lot of times, associate with it. So, because of that, some persons refuse treatment. Now, not just that they refuse treatment, some may just refuse the treatment within because they don't want to have any history of being managed for certain things. But But whatever the case, I would just love to know what percentage of persons really underwent therapy and what the outcomes were. So this is what we are looking forward to looking at. Usually, normal annual medical fitness.
Examining the abdomen. But an adult that knows that if I say this place is paining me, I will not be put on this trip. We bear that pain and not disclose it. They rather die trying. So when you're using this, so that's one issue with mental state examination, because this person, of course, they are in control of their mind, just that sometimes mood swings and all of that. So they try to, and besides that, the person coming from mental fitness was stable enough to dress up to come. So that person can be very subjective with the information they want to give. Having been that, you are going to ask me, how do you feel about it? And I will tick. So I don't know how you
I quite agree with you. But then you see, like I said, in my very first statement, mental health is becoming increasingly important, and a whole lot of campaigns, a whole lot of awareness has been created around this. Now, ability to make people confident enough to give out these details is based on what the culture within the company. So this is what we have been driving. And then no, a lot of times it's been driven, we've said it over and over again. It is to issue them, how will I say it, all the support they require. It is not about, filtering out those with issues. Thank you. Yes. In fact, I really do agree with you. You will see that part of the way we coined our statement was females were 3 times more likely to report symptoms. We did not say had, but more likely to report than the males. Meaning that it's actually what based on the feedback. So there are persons who probably may not have expressed it the way they should. There are some men who probably might have expressed it. So that was a major limitation. The fact that
even skewed it. That's why it appears the women have more of it.
no, but aside that, generally across board, in fact, most of the studies you would come across. Females always have health. No, aside health seeking behaviors, generally the burden on them puts them at a point where they just have to, seek help. Something like this.
And I think this is the way to go. But firstly, the hard scale, was it the same scale used in other studies with comparative analysis?
Yes, those actually use hard scale. Those were the studies referred to, except the WHO, who actually use just the general prevalence of anxiety and depression. No matter, there could be a lot of ways in which they were assessed and diagnosed before. Except that, except that.
Another reason why the offshore workers may have been determined to have less severity than onshore. You spoke about, the anxiety control issues and all. Offshore workers generally, because that's
Pre-selection.
the pre-selection and the environment. Those guys, so they are offshore. You can't reach them. So, as it sounds, that's true.
You're right.
They are not likely to spend any 1 naira for the 28 days they are going to be there. And they are going to tell you that because try to pull, I'm trying to promote.
No, you're right.
And they tell you, okay, no, this is
I'd rather stay away.
28 sanity when they're offshore. When they come back, let them face the challenges they have. Once they go offshore, this whole day, nobody can lift them up.
I agree with you, 100%. I agree with you.
One way to deploy this findings and this tool, like she was trying to propose, is doing medical evidence assessment.
That is where we got this.
I actually understand where you
Okay.
get this from. Propose it in such a way, for instance, what you did. You propose the findings to it such that
Minutes, 3 minutes more for the poster session. 3 minutes more, please. Thank you.
that way you do not have, yes, some people may try putting the tool who understand the intent of it. 3 minutes. Most times, just like you do drug and alcohol, you sign your consent, you feel it anyway. So this may help us to identify data. You're doing it, some other of us are doing it. A lot of people
Are not doing it. Okay, so a recommendation to that body so that it becomes a well. Okay, ma'am. For 2025, yeah.
This is something to go.
I think we're just beginning to start to use it now. Was it October? Yeah. Okay. October. Okay. Thank you. Okay, so please let me give him show him a copy. Hard tool. Just Google hard tool. Now it has just Google if you're going to find it. It has 14 elements in it. Now 7 assesses anxiety. The other 7 assesses depression. Now the questions, there are various segments, 7 segments, and then the various questions under it are graded 0 to 3. Now it asks about feelings, mood, all those symptoms around anxiety and depression. That's what it asks. And then in the long run, you now sum up the scores. When the person is feeling ticks, 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 the person then sums up the score. So for anxiety, you can have a maximum of 21. For depression, you can have a maximum of 21. So for each one of them, you now categorize what is the score of this person. Is it less than 7? Is it less than 8? Is it between 8 to 10? Is it greater than 10? So greater than 10, those are the persons who actually have significant symptoms. Then between 8 and 10, that's the borderline. May or may not. Sir? No, it's the borderline. Have some symptoms. Now, it's not left for you to decipher how well does it affect this person or not, so that's the borderline. Certainly. But most times, in fact, from what we've seen here, these sets of questions are different. The sets of questions are different, yes. So the sets of questions that you use to assess anxiety are quite different from the questions you use to assess depression, yes. And then when you assess them, there's a scoring. Now, this scoring is what we say is the same for both 0 to 7, 0 to 7 normal, and then between 8 to 10 are the ones that are borderline, and then above 11 and above are the ones with significant symptoms. Yes. When I say progression,
anxiety, chronic anxiety.
All right.
Well, it can, but using these two, that is not, is either you are here or here.
All right, ladies and gentlemen, distinguished delegates, if you can hear me from wherever you are, outside the facility, please come inside the hall. Thank you.
Thank you. This is where. Here is it.
No,
self-administered.
So because
self-administered.
Looking at it,
yes.
If somebody
All right, please come inside the hall. Thank you very much. Please come inside the hall, everyone. Please come inside the hall if you can hear me from wherever you are. outside the hall, please make your way into the hall. Thank you. Please make your way into the hall. Thank you very much. Please make your way into the hall. If you can hear me from wherever you are, perhaps you're at the registration desk, perhaps you're close to the 7-point, perhaps you're somewhere around the exhibition area, please make your way into the hall. Thank you very much. Thank you. Thank you. All right, so we will have lunch next, and once we're done with that, we'll come back. Thank you very much. That's fine. So we'll have lunch next, and once we're done with that, we'll come back into the hall for the final set of proceedings. Please, let's settle down. Thank you very much. Let's all settle down. Thank you. Let us all settle down. So we have some announcements that will be made by the National PRO, Dr. Charles Onigbogi. So once he's done with those announcements, I will announce the modalities for lunch. Ladies and gentlemen, let's settle down and listen, all right? It's very important that we pay attention to these announcements. Thank you.
Good afternoon, distinguished ladies and gentlemen. I hope you are having a wonderful time so far. Just some quick announcements regarding the outstanding conference bags and other packages. Okay, we would like to apologize for the inconveniences so far. For those of you who haven't gotten, we had budgeted some bags, but we've gotten more delegates than expected after we have done the order, and these bags came from outside the country. So we're going to do a reorder. We have the list of those of you who haven't gotten, but we'll pass in a list so that you can revalidate your names and sign with the secretariat outside, so you can confirm your details and send your bag as soon as they've arrived. So it's very important. Don't go without documenting your name that you've not received your conference bags and brochures. Also, there will be an LOC meeting immediately after this conference today. So LOC members, please stay behind. Then all members of SOFON year, new and old, we would like you to visit our SOFON website, www.sofon.com, to register yourself there as a member. You need to get your own membership number through that website. It's important. Apart from paying your membership dues, you also need to go onto that website and create your own membership account on that portal. Very, very important. So if you can do that today, it will be good to do that as soon as possible. As more announcements are available, we will bring it to you. Thank you. Again, apologies for the inconvenience about the bag materials, conference materials. We'll get it as soon as possible. Thank you.
All right. Important announcements by the National PRO, Dr. Charles Onigbogi. Thank you, sir. Thank you for those announcements. All right, ladies and gentlemen, officially it is time for lunch. But just before we do that, please be advised that once we come back from lunch, we'll take short interventions from 3 speakers. After that, there will be a panel discussion. The focus will be on confidentiality and consent, and we will be exploring 3 or so case scenarios in that segment. One speaker will open that conversation, and after that, we'll have our panelists add their voices to the discourse. So, ladies and gentlemen, that is it. Lunch is ready. Lunch is ready to be served. Just remain seated at your table. The ushers will come to you and ask you to proceed to the 7-point table by table. We don't want you to spend so much time on the queue, so they'll come to you and ask you to move to the 7-point where you'll be served your meal. So lunch is ready, ladies and gentlemen. In the meantime, there'll just be some music in the background so we can all enjoy the moment. Lunch is ready. Please remain seated where you are. The ushers will come to you and direct you to the 7-point where your meal will be served. So, thank you very much, ladies and gentlemen. By my time here, this is 1:39. So I imagine that in the next 45 minutes, we should be able to continue with the rest of the program. Remember, when we come back from lunch, we'll take brief interventions from 3 of our speakers, and after that, we'll move straight to a panel discussion. To open that panel discussion, there will be a short presentation on confidentiality and consent, and yes, we'll also explore 3 or so case scenarios. After that, our panelists will add their voices to the conversation, and we'll take closing remarks, and that will be it. Remember, ICOH members, you'd have a side meeting today. ICO, all right. ICO members, you'd have a side meeting today. Thank you very much. That is also very important information. Please be advised of that announcement. Thank you. Enjoy your lunch. Thank you.
Stop.
just carry on. I don't know whether some people just stop, you know, to them, just technology, no, just carry on. If not, you do, or unless you go back. Yeah, so that's why I'm saying, I want to know whether, but today we have many more stations. The other day I don't know, and you are doing it, I'm doing it now. It's working. What I wanted to know is whether put the QR code or just the link. I just put the link. If I put the QR code, if I put, because you can share the QR code, of course. Yeah. So people should have look at this. Look at the basis. So that you've already answered. So I'm through now. Okay? I'm just I don't know whether if you scan this QR code to join. Whether now what I want to see is I want to scan this code to see whether if I scan it this code. That's it, trying to get our acts together very well. You to scan the code and see whether to allow you to put the video now see what it is. Okay? Vibration. Sure. So this QR code is opens it. I can put the slide as well. I can put the but my problem is now with this one. I've told today. So this QR code is fine. I'm just thinking let me just fix that. I just put it there. So people should just see whether it will work. I'll give you
change, to initiate and bridge the business development gap between sectors, and in this case, SOFON, in the climate change movement, and to model collaborative engagement within the occupational and environmental health space. So this engagement, the private sector engagement, held in July 8, 2025. The initial engagement had stakeholders from the environmental space, and there was a heated debate on whether or not the focus for research should be on adaptive or mitigative model. The take home after 2.5 years is that the ministry eventually realized that the way to go is adaptation. So on this particular day, we had this outline in discussing the climate change action plan. So based on the Paris Agreement, which was done in 2015, the collective goal is to keep global warming less than 1.5 degrees centigrade. And that by 2030, to reduce global carbon emission by 45%, and to have net zero emission for 2050. Now, last year, the United Nations Environmental Program, when it had its conference, had its target as reducing waste products, significant waste. And that's why you see all these PET bottles being, transported and all that. But this year, the focus is on zero emission, and that focuses a lot on companies and industries that emit carbon. So the collaborative model here was that we had people from the academia, we had people from industry, we also had people from other ministries. I'll be highlighting that very soon. The people from academia showed that there was local investment and funds uptake, which means there are funds available for research and projects. However, there was low intake, and out of 100 submissions, only 48 were selected, and the selection process is extremely vigorous. However, after the selection process, most of all these projects were not bankable, which means that whatever project that you want to, propose and submit must get up to the bankable project. The good thing is that the commissions who are looking at these assessment processes are also committed to making sure that your projects can be bankable if nominated. Okay, so after this session, we asked critical questions, and it was obvious that stakeholders are working in silos and that there was no framework to bring the stakeholders together for gathering of information, surveillance of activities on climate change actions, and funding, access to funding. These are the different sectors that were represented in that engagement. So I'll speak for the energy and industry, as if God just knew that I was going to be here, and my space is certain, whether you like it or not. So I was nominated to be in the energy industry, and these are the team, the people who were involved in this energy and industry. So the first thing we did was to quickly delineate
all the other industries, because we're literally like just two other industries. So we highlighted other industries like power, utility, mining, extraction. So we added almost like 7 out of all this. I know Julius Berger is here. So I think we can begin to look at all these other industries for our research focus. And then during this particular session, the questions that were asked, the discussion points were to look at carbon capture, utilization, and storage in most of all these industries. So we had 2 sessions of assessment by the discussants. The first part of the discussion was looking at the industry, and more focused, we looked at the oil and gas industry. So the opinion by the discussants or the collaborative efforts of the people there was that there's need for us to profile industry-specific carbon emission and footprint, and that most of the times that there should be tax breaks to intensify innovation. Now, the profiling will help to put the industries based on their emission level, and whatever intervention that will be done will also be based on this. So our opinion is that our opinion on this particular discussion point is a bit low. Then, should there be decentralization and clustering of any energy utilization? We think that yes, our opinion was highly placed on this. We looked at the fact that there's modular generation of energy in some states already, and then some particular industries are beginning to do their own energy supply. Should there be immediate shift to bioenergy sources? We have the opinion that it should be a progressive thing. Should there be elimination of gas flaring by 2030 and net zero emission by 2050? So we acknowledge the fact that although industries are already adopting alternative cleaner energies production processes, there is still unquantified gaps. So for the oil and gas, all of these discussion points were held, which means that should there be carbon capture, utilization, and storage, there was urgency in our response that it should be a priority. Immediate shift to bioenergy sources, a priority. Elimination of gas flaring, a priority in oil and gas. Sole use of renewable energies gradually, but a priority by our own opinion. Should there be provision of 50% operation energy demand? Yes, but there should be a mix, and depending on the region. So after this session, we highlighted the fact that there's a huge gap in accessing the funds, and also the contribution from the sectors, either the oil and gas or the industries. So current and planned investment is 0. And remember when I started the presentation, I said that Nigerians' commitment level is actually as high as the US and some other companies. So right there at the engagement meeting, they proposed percentage contribution that they think that the private sector and national public would be. Now, under risk assessment, which was looking at some thematic areas, the highest from our observation was that there's need for capacity building in research. There's need to have local engagement, competitive platforms for innovation, and there was a lot of gap in technology. So what are the opportunities for SOFON? There's funding for translational research. I like the fact that there was development of a tool from one of the research that we did. So most of our processes, if we're content development experts, that means that we'll have enough content to give to the IT guys by the time they come in to, the climate change space. Then there's
there is opportunity for green transition, which means that whatever proposal you have can actually give you access to the funding to convert your hospital or your setting into a green-friendly space. And then I talked at some point about the ESG framework that will be a standard for assessing facilities, companies, hospitals in the nearest future. So the earlier we get into this, the better. So one of the research that Professor Mokodion, my mentor, that I was seriously involved in when I was doing my residency was looking at artisans, you know, their health risk. We looked at their health needs, we looked at their health risk assessment, and there were quite a lot of them that I was personally involved with, and I'm grateful for that experience. Now, for this, we can actually look at translational research where we can do the environmental effect of climate change on these artisans. So we're merging here a strong statement on environmental health and occupational health practice. So we made some conclusions. I think the emphasis on the conclusion and recommendations made was that there should be involvement of pressure groups like this. There should be high collaborative effort, and that we should maintain and monitor project transparency. Policy direction, there should be large-scale clean energy bases. We should have carbon border adjustment mechanisms like in China. Thank you very much. So what I've done, literally, is to stimulate our appetite for climate change effects. In recent times, I'm sure you've seen a lot of fungal infections. It might not be in the oil and gas, but you know, we can combine the artisans level, looking at the general population, looking at the occupational setting, and also bring a large form of data on board. Thank you.
All right, climate change, protecting the environment is a collective responsibility, and we all must play our parts towards ensuring that that becomes our reality. Thank you very much, ma'am. Dr. Adora Obiagu, thank you for that presentation. All right, please join me to welcome our next speaker, who will be speaking to us for the next 7 minutes, the National Secretary of ICO 2024 to 2027. Please make welcome Dr. Ahmed Mohammed. A round of applause for him as he takes the stage, ICO National Secretary for Nigeria 2024 to 2027. And after that, we'll also take words from Dr. Warren Silverman for the next 5 minutes.
Good afternoon, senior colleagues and colleagues. How was lunch? Hello? How was lunch? Okay, please try not to sleep through this presentation, because after eating such a sumptuous meal, it is very tempting for people to doze off a bit. Welcome to this session of the presentations. No, I don't. Thank you, Prof. So I'm here to basically tell us a bit about ICO. I'm sure a lot of us are aware of what the International Commission on Occupational Health is about. It's one of the longest standing NGO on workplace issue, established in 1906. It's a UN recognized expert body on the regulation of workplaces. And you'll agree with me that our main focus in this society is to make the space of work more conducive and safe for people. ICO holds a lot of conventions, webinars, and congresses to try and be like a pressure group to make countries on a global scale to advance the cause of workplace health. People die, we heard statistics, thousands die every day from work-related incidents. So ICO's main objective is to galvanize all persons in the field of occupational health practice to make this space safer. So we are physicians in the Environment and Occupational Health Division, but we have other groups like the occupational hygienists, the safety professionals, and all nurses, pharmacists, everybody working in the healthcare space that can impact on the worker is welcome under the umbrella of ICO. We are very lucky in Nigeria because I can announce that in the most recent ICO plenary session held in Naples, the Board of Trustees of ICO found it that our region of the world, that is Africa and low-income countries, we are underrepresented. So the president, with his constitutionally authorized power, approved the appointment of Professor Shade Omokodion to be on the ICO board. So I thank you very much for that one round of applause. And indeed, it's a big achievement because it puts Nigerian issues on a world pedestal. So through Prof, all these presentations we have made today can get global exposure, such that, like the presentation on the quarry, the main complaint was, challenge of funding. Another person's own challenge of funding. There are people out there who are looking for such kind of research that they want to pump money into. I was appointed at the Triennial Congress meeting in Marrakesh, Morocco, in 2024. So ICO holds its conferences once in 3 years. So they call them Triennial Congresses. So the next one is going to be in Mumbai in 2027. So please let us start getting ready to, first of all, register as a member of the society. In Nigeria, we have 88 registered persons, 88. But unfortunately, only 1/3 are what we call in good standing. Good standing means that only 1/3, in fact, 18 people in Nigeria are the ones that have paid their dues up to date. And how much is the dues? 45 Swiss francs. In today's currency, is 81,300 naira. So you divide that by 3, it comes to an average of less than 30,000 to register to be a member of the International Commission on Occupational Health. Now, it gives you a big, wide pedestal to access so many researches happening all over the world. There are many ICO regions, especially the Latin America and the Pacific, where they're doing a lot, and they're trying to make Africa to come along. The president of SOFON will tell you that there are a lot of bodies. When we were in Morocco, they call us to a room, ICO members from Africa. What do you want us to do for you? I'm telling you, practically as if go and bring a suitcase, so we'll give you this money to go home with. So they want us to come up with ideas. So they even form an association that parallels what the Medecins Sans Frontières does in the field of clinical and emergency medicine. There are people who have volunteered, expertise, technical support, name them, that have volunteered themselves to see how they can support research and intervention in the workplace. We've had 1 or 2 webinars with the team, and then they give us things to follow up with. But of course, you know, a lot of the things they ask for instance, I got an email, I reached out to my predecessor, ICO National Secretary, Dr. Uche Inuma. They ask, what are the commonest occupationally prescribed diseases that we are seeing in Nigeria? Please, is there any repository of such information in Nigeria? Pardon? I know Ministry of Labor ought to have it, isn't it? Yes, I went to the ministry and then I was told that I need to write to the minister, and the minister will probably need to get approval from the president. And you know how this bureaucracy, but these are things that we ought to have readily available such that we can together design intervention programs to mitigate these things before they become national emergencies. We have this lead poisoning issue now. Is a topic that if we present before the world of ICO, international bodies, they've done it in other world. They won't need to design anything special. They'll just come and translate what they've done in other parts of the world. So please, I want to urge all of us that are here present. The challenge I was also discussing with Prof and some other colleagues, the president, is that because ICO does not have a governance structure, so to say, apart from the national secretary in the country, there is no other official of ICO in Nigeria. So one person is supposed to share information about ICO to all Nigerians, 220. We are supposed to also coordinate networking. I'm supposed to organize meetings. I'm supposed to get people to do research that are related. It is impossible. So I came up with the idea that because SOPON is my own primary constituency, we should leverage on SOPON activities to advocate and advance ICO initiatives. At the AGM, maybe we'll do a position paper that whoever is the ICO National Secretary for Nigeria going forward should be given, I don't want to use the word honorary, but an opportunity to be like an ex officio on the SOPON Executive Council, such that you can interface between these two bodies. Then I also share idea with the president of the Occupational Hygiene Society of Nigeria, who happens to be in, she was in the room earlier today. I don't know if you are still here, doctor, that we should form a governance structure at that level where, you know, everybody. So at the level of health practitioner, we can have the occupational hygienist, and everybody will SOPON this category of members.
And one thing is wildfires. And I mention that because I just got some data last week about wildfires. 440 million people in the world every year are threatened in their households by wildfires encroaching on their house. 85% of those people are in Africa, but only 2.5% in the US, Europe, and Australia. And yet, all the literature is about what happened in San Diego and in Canada and in Australia. That's wrong. That's wrong. I think Africa needs to have a voice and let people know about things that happen in the environment and in workplaces here. Now that brings me to the ICO thing. We have bulletin boards that are established to look at occupational medicine globally. ACOM just put a person on the ICO board that's also ACOM. One of the things that I see coming up in the last couple of months are doctors around the world dealing with electronic vehicles, EVs, and battery recycling, and the lead is a big issue globally. I think if we bring in not only Nigeria, but some of these other places where people are dealing with all this battery waste and all of the lead, you can provide a perspective along with what other people are seeing and put on a great presentation. And I would encourage you to think about, because the lead issue is a big one here. And I think you've got some information, some data, and whatever, but you also have a problem. And I think bringing that out to the global environment at an ICO meeting, along with other people that are facing similar issues, would be absolutely great. So I would encourage you. Now, the one other thing I've got, last year, after I came to the meeting here, I was asked to come up to ILA-FA to talk about putting together an occupational health course. When I got there, they said, what we would really like is a 2 to 3 day course on maritime safety and health. I don't know anything about it, but I found some people in Finland, the US, that know a little bit about it. But I'm looking for people here that might be interested in being part of that group to put together a course that would be a virtual course. People could get certification for inland maritime work, port safety, and overseas as well. And if anybody's interested, please come to me and give me your contact information. We'll probably have a Zoom call in the near future with some of these people. In fact, the president of ACOM right now was a Navy occupational medicine doc, so she's even interested. So I think we could put together something, maybe a couple of days of safety, 1 day of health, that kind of thing. And I'd be appreciative of any help you might give. We don't know how much would be virtual, how much would be webinar, how much would be live. But it's up at ILA-FA, at the university. Thank you.
All right, thank you very much, Dr. Warren Silverman. Thank you very much for that brief intervention. All right, ladies and gentlemen, distinguished guests, this is the final session and the focus is on patient confidentiality. And to open this session, we'll have a short presentation, after which we'll have a panel discussion. So ladies and gentlemen, you already have on the stage, or behind the lectern more like, Dr. Michelle Ojumo. Ma'am, you have the floor.
So good afternoon, everyone. Good afternoon, everyone. So I want to ask, how many of us work in private companies? Private companies, good. So we're going to be talking about our dilemmas as OHPs when we work in private companies. So I'll do a brief introduction. Sorry, the slide is not moving. No. The slideshow mode is not moving. Let's pick this one. Sorry. Okay. While we are trying to sort out the IT issue, let me just continue my talk because of timing.
if I think it's going to protect the public, protect their coworkers, protect that employee, basically won't do the job.
All right. Okay. Thank you so much. Thank you to all of you.
Sorry, just one more on this.
Yeah.
So let's assume that the employee did accept to disclose. For me personally, I will still be wary about letting the company know why I'm still declaring on. So it will be a functional report, but not to say she's agreed for me to tell you she has spinal spondylosis. So I think we should also keep that in mind. That even when they disclose, and I have people who tell me, it's my job, please tell them everything that is there so I can get help, especially when they're looking for funds from the company. I go like, no, they don't need to know your diagnosis, but I'll make the case that you have something that we need to pay for, So I think that's important.
Okay, and I think thank you to all of you. I think the second case is similar to your last comment, where we are talking about a doctor who has the dual role of being an OHP on the one hand, but also undertakes primary physician care responsibilities. And it is during one of their primary physician care responsibilities that they became aware that an employee was involved in an accident, and they had provided a sick note for this employee to be absent from work from the injuries they sustained. Now, the manager of the injured party received the sick notes and visited them in the hospital to see how they were doing. Then this manager called to the doctor to know what the condition is, the treatment it has been. It's similar to what you were saying, Dr. Okuns. Do we want to say anything on that, Dr. Lulumari? So to simplify, this is where a manager is demanding more medical information.
The manager wants to know what I will tell the manager is the fact that, okay, your employee has an accident, and the way it is, he cannot be at work. But if you want to know the details, I need to obtain consent from the patient.
Right.
For me to disclose to you the extent of the injury the patient has. So that was the way I would tackle it.
Thank you, Dr. Lulumari. Let me open up the question a bit more. Is there any grounds for management for an OHP to give management full information, medical information about an employee? Is there any grounds, even after that employee had given consent, full written consent, for management to have access to their medical information?
I think it's the managing clinician or the managing practitioner that has that right. It's not the...
Yeah, so the question is, do we have any situation in which the doctor will be justified to provide every medical information, since the patient or the employee says, yes, you can tell my employer?
I don't think so.
Okay, you don't think so.
It's in conjunction with other practitioners.
It's in conjunction with other practitioners.
Yes.
Dr. Okuns, I see you shaking your head, and that draws my attention to you.
They say I wear my emotion on my sleeves. Honestly, first of all, this scenario is perhaps the most common one we face in private hospitals that are company owned, where you literally even have the MD or a GM insisting they need to know. I struggle to find any circumstance where HR or a manager should know the diagnosis. I can't think of any, no matter what it is. Even if it's a communicable disease, my duty of reporting is to the local government, not my HR. My duty is to make a functional call and to protect the people appropriately. I can tell them it's in their safety, blah, blah. But to give that diagnosis, because it doesn't change anything. What are you going to do now? You know the name of the condition. What you need to know is get my advice on how the workplace should adjust or what we'll do for the person.
Dr. Okun's managers are very insistent.
Yeah.
And particularly in the world of outsourced occupational health provision, they threaten you with contract withdrawal, they threaten you with loss of business, they threaten you. And unfortunately, your neighbor across the road has very low threshold for these ethical standards. They will do it anyway before thinking. Before we come in, I know you've got a lot to say. I see reactions in the room, and I thought we should allow participation from people within the same. I see one hand there. I see one hand there. Three people. Okay, let's go. Okay, one way. That's one other way. Yeah. Okay, Dr. Ngozi first.
Okay, so good afternoon, everybody. I'm just reacting to what Dr. Okun just said. I think he made a statement. I just wanted to, stretch it a bit further because I didn't understand. He said, even if it's a communicable disease, there's no situation where you're going to divulge that information to the employer. And I beg to differ, because if I have to do contact tracing for his colleagues in the office, I will need to know, they will need to know that this is what I'm doing and why I am doing it.
Okay, thank you so much, Dr. Ngozi. Let's see, Dr. Okpawaye, did you raise your hand? Or you put it down? Okay, that's fine. Okay.
Hello. Somebody's got the second
hold
mic
on.
here.
Is that Dr. Okorocha?
Dr. Adekunle.
Dr. Adekunle. Dr. Adekunle then.
All right. I agree with Dr. Okuns in saying that there is no reason why line managers should know diagnosis. It is privileged information. And when you work with people, you don't want your manager to look at, oh, this is the diabetic case. This is the hypertensive case. This is the lumbar spondylosis. That's not the job of the line manager. Even in communicable diseases, we managed COVID, we did contact tracing. All we did for contact tracing was, we have reasons to believe that you may have been exposed to one of your colleagues and we need to monitor you. We need to protect the workers. And when we say to the manager, let's go to the employee and get consent, we are setting up that employee. We are putting the employee in a difficult situation. And if the employee says no, what do we do? So that means the doctor is willing to disclose, but the employee is not willing to disclose to the manager. So, and there's going to be performance assessments.
Okay.
So my summary in this is, as occupational health physicians, we need to stand in that gap and protect the employees while also protect the workplace.
Thank you, Dr. Adekunle. I will have room for one. I have room for one, just one more. Sorry, Dr. Uche, I'll give you a chance next time. Yes, please. Now you are putting the gender thing in. Okay. Please, him first, and then I'll take Dr. Kemi. Don't worry, you'll get a chance. No, give him the mic, please. And then we'll come back to yourselves and Dr. Uche.
Thank you very much. Good afternoon, everybody. Okay, so two things. So I think, just like what he said, usually when we engage and we're getting history during the whether fit to work or consults, is a privileged information. And it's supposed to be restricted to the purpose for which that information is being obtained. So if you're actually getting an information from a worker for his job in workplace A, so it's just for the purpose of workplace A, and it's assumed the scope of that health check also puts has embedded in it the every thing that should assess the person's eligibility or ability or inherent ability to be able to do the job, and it should be restricted to that purpose. So should you find it, and it's a privileged information which should not be divulged under any circumstance. So if you find this person in workplace B, irrespective of what you know,
So you shouldn't bring what the information you have in workplace A to workplace B.
Okay.
So one more thing. So I think it also means like what we talked about when we scope health checks. If at the time you came and you met her in workplace B, working or doing a certain job, if the scope of the assessment had not determined that she was not eligible to do that job, so probably, perhaps, maybe there was a gap in the scope of the health assessment that determined that this person was eligible to be engaged as an emergency nurse. So hence, she has been cleared. Under no circumstance should you now bring up a history which was privileged from workplace A.
Thank you. I think you introduced one principle of data privacy, which is purpose limitation, where the consent is limited to only the purpose for which it was sought. Okay, thank you. Dr. Kemi.
All right, so very interesting conversation. Now I have a dilemma. I agree with Dr. Oku, Dr. Adekunle, but in practice, particularly in situations when this patient requires special approval, medical costs, way higher than covered by HMO and things like that, or this individual has to be flown abroad, or this individual is unconscious and needs loads of, we've had patients in ICU for 3-4 months, a lot of money. And management will ask, why do you want us to spend this much on this patient? It's difficult to say at that point. I'm not going to divulge more information than necessary. So how do you deal with that?
Okay, so to respond to that, and just in the interest of time, I'll give Dr. Silverman an opportunity. I'll give Dr. Olumbi an opportunity. Okay, let's do that very quickly. Similar question to Kemi's question. Okay. No. Here, it comes back here. Thank you. And Dr. Silverman.
Now, the legal system, of course, in the U.S. is a little bit different. But one of the rules is follow the money. So in the U.S., there's a difference. If somebody's injured on the job, it's carried by workers' compensation insurance for work injuries. If they get injured off the job and they can't work, that's covered by a different insurance called disability. Okay? Now, the importance here is who owns the data. Okay? If they go to a primary care doctor, if they get treated for disability, that data belongs to that patient. Okay? Now, if that patient says to me, my supervisor's got an uncle and he's a doctor and I'd like to let him see the file, I'll say to them, here's the consent, I'll give you the file, you can give it to him. I don't have to give it to him. It's yours. Okay? Now, on the other hand, on the workers' comp side, the supervisor definitely has known, I go by the need to know principle. His supervisor doesn't need to know his personal medical. All he needs to know is, does he have a limitation doing his job? Is he safe to do his job? And that he has a medical condition right now that's keeping him out of his job. However, there are people in HR that have to process the claim, so they have access to the medical record, but no supervisor should. Nobody who oversees the person, unless it directly, say the guy loses an eye, and he's a truck driver, and I need to let the employer know that may affect his ability to perform safely. That's on a need-to-know basis. But medical file that belongs to the employer's workers' comp, medical file that belongs to the patient is non-workers' comp disability. And you have to keep those two separate.
Thank you. I take one final contribution from you and we begin to wrap up. We'll take one more scenario and then we'll begin to wrap up.
So my own comment will be this. In my own setting, I put it that way, my own setting, it's a little bit different from what I'm hearing here. Now, The connection, basically, that's on a documented basis between myself, the patient before me, and management will usually be a report that I will probably write. So the contents of that report now depends on what I get from the patient before me. So if I have his consent to now give full disclosure of what he has, I probably will just couch it properly and then know how I'm presenting it to management.
Okay. Thank you so much to all of you. Thank you for your thoughts. Thank you for your insights and the perspectives shared. It will not be, hold on one second. It will not be a conversation around a topic like confidentiality and consent without this kind of things. Okay? I want to use the third scenario. Okay? I want to summarize the third scenario and then give the two people that I owe recognition an opportunity to comment. Okay? On the third scenario. Okay? So to summarize, this is a situation where a doctor, an occupational health physician, is aware of another colleague's accommodations and adaptations at work because of an existing low back problem. Okay? But the problem is that this person who's been accommodated in their current role, possibly for example, exclusion from manual handling and things like that, is having a secondary role where they are undertaking those same activities for which they have been accommodated in another employment. Okay? The question, the dilemma there is that on the one hand, this is the same person accommodated here, but then they find the person is capable of doing these things. Dr. Power, you wanted to say something. I'll take this to them.
It's on now.
Is he on? Okay, thank you. Yeah, thank you very much, Dr. Jai. I was going to make another comment, but quickly on this one, I think people can work in different places with different terms of service, different job descriptions, and different salaries. So I think it's, I don't know if that should, the knowledge of what he was on before, for me, that's just what I think. And I'm just basing this on what I think. I think they may have different conditions in different areas. So even though he's doing that in another place, I mean, I think it's up to him. That's my own view, especially if it's not going to affect the quality of his output somehow. If he has been able to negotiate that into his present contract, that's my own view, no problem. But on the other issues of confidentiality and all, I think sometimes my own primary specialty is infectious diseases. And in infectious diseases, there's a lot of duty, apart from duty to the patient, we also have duty to the public. And that's why in a lot of places now, if you have a couple coming in with HIV, and it's serodiscordant, there's one positive, the other one is negative. The other one negative must be aware, because you have a duty to her or to him to make sure that they are also protected. So even if the primary person refuses, there are times when you are allowed to break such kind of confidentiality.
Absolutely.
I think it's important.
There are conditions and grounds for breaching medical confidence, and one of them is in the interest of public safety. The other would be when a court orders that the evidence be disclosed, and when there will be harm to the individual themselves and you could do something about it. So under those conditions, there are established grounds for breaking medical confidence. Dr. Enuma, you want to respond to this one, I believe.
Yes, but before that, please, permit me to respond to the previous, because it's very important. You know, Okun's presentation was very apt, and almost all of us agreed. But that's the ideal, because there is a question we're not answering here, and that's where we are supported. And I believe that's what this conference should address, right? Are we addressing the prevailing culture, the workplace culture under which this is occurring? It is very easy in the private setting, especially in multinationals, that have respect for different disciplines, and you are able to practice your profession, this confidentiality matter is taken to the extreme. You know, DA issues, diversity, and this thing are very well respected. There are other cultures where these things are thrown into the winds, and you have to still be an occupational health physician. What do you do in such situation? Because it's very easy for you to stand your ground and say, no, I'm not going to disclose anything to anybody. I have duty of care to this, I have duty of care to this. That is just idealistic. When you are in the government settings, in the real world, where most of us will find our place, we should be talking about how to gather skills on how to handle matters like this, rather than just throwing this thing into the air. Many people will now go home now and thinking that it's just so easy for you to just tell your management, no, I cannot do this. My friend, do you have another job? Are we communicating, please? So please, we should be thinking of skills as practitioners. How do we address issues like this? And I think two things are important here. Policy issues, okay? How do we change the workplace culture we find ourselves? How do we interact with management to such a level where they respect our discipline and what we do? So that when we are confronted with such issues, it will not be the first time we are defending it. I don't know whether you get my drift. So it will now be that this is what obtains here. So when you now say you stand your ground, it will be respected. If you have not established that before now, I tell you, in most workplaces where the majority here are working, if you say you are insisting on this and that, my friend, better prepare for you know what I mean.
Thank you. All right. I think we need to round up. We need to be mindful of time and the remaining activities that we need to complete. Final words.
Final words. So I did 16 years in the government sector. 16 years. Village Teaching Hospital, Irua, UBTH. I'll give you a quick one. When I started practicing in UBTH, which had a very well-established family planning clinic, my first surprise was that they used to tell me I need to get the husband to sign when I want to do a BTL. I was then a registrar, and I said, sorry, it doesn't make sense to me. And I never did it, because I was pretty clear about what my duty was to the patient. Forward to moving to Shell, to one of the oil, it wasn't even Shell, so I can say it. To one of the, and I got in and found out to do a cesarean section, I needed to get the staff's consent. And I said, I'm not bloody going to waste time. What's his business? In short, why do I even have to tell him what I'm doing? And it starts with knowing what is right. I'll end it like this. It's very easy to say the culture and all. Wait till you have to pay $300, $400 million for a legal case. Then you understand what we are talking about. And we've had cases that come after us. There's one we have now, 20 years after the death of the individual. These things are real, and they are coming. So those on the government sector, you may think it's not a big deal, but you wait.
All right, thank you so much, Dr. Kunz. Thank you to our very eminent panel. I think before I release you, you have the final words.
The final words from me. Okay, for us as doctors, OH practitioners, I think we should take more training on ethics in medical practice, because what obtains in some sectors may not obtain in others. But there is a general ethical practice document in Nigeria, which the lawyers can actually put us through. We just had a training on that in my zone. So some of the things we didn't know were able to be told, because something you think may be right may not be right. So we should take more lessons.
Thank you.
And more trainings
Dr.
on ethical practice.
Dr. Lumi.
Because a lot of litigations are ongoing at the moment.
Absolutely.
Thank you.
Thank you, Dr. Lulumar. Dr. Lumi, final words?
Very simple. Industries are different. So you follow what the mandates are. And as she said, ethics are talking about confidentiality and consent. It's still the same thing that obtains anywhere. Your patient is your king, is in front of you. you owe him that respect to keep his records confident. But if you have to disclose, consent needs to be taken. But what do you now do in cases of maybe not adults this time, probably adolescents and children? That's a question I need to ask.
Another tricky area.
Very tricky, right?
Another tricky area.
So you need to play it by the book, but at the same time satisfy all parties.
Thank you, Dr. Lumbi. Dr. Silverman, final words.
Sure. I was originally trained as an internist. I did internal medicine from 1978 to 1986. Then I started occupational medicine. The difference when I deal with these situations is when an orthopedist sends me a note, his only customer is that patient. And if the patient says, you know, doc, I don't feel like working today, or I've got a vacation coming up, could you write me out a little bit longer? He's going to be inclined to try to satisfy that patient, make him happy. As an occupational medicine provider, patients are sent to me by employers. I'm paid by the employer. I'm an agent of the employer. That person in front of me is an employee, and I'm trying to do the right thing. I don't want to hurt that employee. I don't want to send them back into a bad situation, but I want to be honest. I have to deal with the employee, the employer, the supervisor, insurance carrier, the safety officer. I am part of a team. So when I look at these issues ethically, I don't go in there as the primary care doctor. That's an employee. That's not my patient. I might not see him ever again. They're asking me to tell if he's safe to work or if he's not. I'm going to do the right thing and get that answer correct, regardless of what the primary care doctor says. I do care what they say, but I'll make my own judgment.
Thank you so much. I think I will just round it up by saying, before I discharge the panel, the subject of ethics is a very, very difficult one. Navigating it can be very, very difficult. Sometimes the decisions and the next steps are very clear. At other times, they are very, very muddied. Okay? There are times where you will disclose a medical information. And yes, we've talked about you should never, but there are times you can. So long should the matter be examined in court, you can demonstrate that it is a reasonable action to achieve a legitimate cause. If you are able to demonstrate that, or your lawyers are able to demonstrate that, you are likely to be let go. But I think the final thing to say is, Dr. Ogunyemi told us this last year, gave us this advice last year. In all your practice, try to identify your 3 wise men. And this is on one occasion where you will need to stand on the wisdom of 3 wise men. If you find yourself faced with a very ethical, difficult situation, do not be the macho. Do not act as if you know it all, even if you are very eminent at what you do. Consult. Choose your consultation partners carefully. They can make you or they can mar you, okay? Medical indemnifiers should normally be supportive in situations like this. In other countries, you could ring your medical indemnity company, they can guide you, and so on and so forth. But when we don't have that sort of access here. When you are here, remember your 3 wise men. There's nothing you learned from the conference today, at least from this session. You should, before you leave that door, think about who your 3 wise men would be. Thank you, everybody. Thank you, eminent panels.
Thank you. Thank you very much, Mr. Moderator. Brilliant wrap-up. You want to pose for a photograph? Okay, paparazzi, did you get that? All right, let's have a group photograph, please. All right, let's have a group photograph. Thank you. Group photograph. Thank you very much. Very, very exciting session. We had the opportunity to listen to perspectives and viewpoints from our panelists and members of the audience. A robust conversation indeed it was. Thank you very much, gentlemen. Thank you very much, ladies. A round of applause for them as they go back to their seats. All right, ladies and gentlemen, we are approaching the terminal point, and yes, at this time to give the closing remarks, please join me to welcome Dr. Fumi Daramola. Please make welcome Dr. Fumi Daramola for the closing remarks. After that, we'll have the vote of thanks and a few announcements, and that will be all. Dr. Fumi Daramola, please. Thank you.
Good afternoon, everyone. Or is it evening? It's still afternoon. Good afternoon, everyone. I'm sure you've all had a very interesting day today. I'm not here to give the closing remarks, but just to an overview of what we've had today, and just to wrap up the session. And indeed, I think it is a wrap. Can we start with a round of applause for the LOC and the BOT, because they've been able to put together such a well-packed, rich, insightful, and well-curated 2025 SOPON conference. And I'd also like you to give yourselves a round of applause because you registered, you came physically, virtually, you participated, and you made it all fun. If they did all the work and you didn't show up, it would be extremely boring. So, the day started with a very exciting scientific session featuring about 9 papers and both paper and poster presentation, and on a wide variety of topics. Of course, we had, this just kind of highlights how wide occupational health is. We had papers on depression and anxiety, and interestingly, the results show that the prevalence of depression and anxiety is very low in the oil and gas. Is that an unrealistic way? Is that an unrealistic place to work? Or is it how it is in real life? I don't know. And I don't know whether the recommendation is that we should all get a job in oil and gas. But that was very interesting. And then we also had something about prostate cancer. And that's the leading cause of cancers in black men. So I encourage everybody to please take a look at the conference program, read up all of the papers, and get in touch with the brilliant minds that were able to put all of that together. I would like a round of applause for all of the presenters. Paper presentation, poster presentation. It really takes a lot of work, a lot of grit, a lot of determination to publish papers in Nigeria. So, post-launch, the lights were still dim then, but Adora, she stimulated our appetite with climate change advocacy, and we also heard updates from the president of ICO and Dr. Silverman of ACOM. So please, I implore you all, do not allow just 45 Swiss francs stand between you and the window to the world of occupational health. Please register as members of ICO. And if you're interested in opportunities in the maritime industry, please see Dr. Silverman. That's part of what he told us. And just as we wanted to nod off, the lights came on, and Michelle and her team, led us through a very insightful and engaging session on dilemma in occupational health. But Michelle, I'm quarreling with you. Your poster was a man, and you're a woman. So why should you depict occupational health physicians as males? I don't know why you did that, but be careful next time. All right, so I'm not sure we concluded, but what I'm taking away from that session is that, it was expertly moderated by Dr. Larry Ajayi. He said you should look for 3 wise men. So whenever you run into trouble, and I'd like us to even take that beyond occupational health discussions. Whenever you run into trouble, you're in a fix, you need money, look for your 3 wise men. This time it is the men. And if you look around you, there are many 3 wise men in this place. So just hang on to them. On this note, I'd like to hand back to the MC for the rest of the program. Thank you so much for your rapt attention.
Thank you very much, Dr. Fumi Daramola. Very quickly, this is an important announcement. All scientific paper presenters should endeavor to prepare their papers to be submitted to the OH Journal. The chairman of the scientific subcommittee will be in touch. So please remember, all scientific paper presenters should endeavor to prepare their papers to be submitted to the OH Journal. The chair of the scientific subcommittee will be in touch. All right, ladies and gentlemen, to give the vote of thanks, please join me to welcome the chair of the LOC, who also doubles as the National Vice President of SOPON, Dr. Lanre Ajayi. Round of applause for him as he comes to give the vote of thanks.
Good evening again. Sorry, please. Apologies. Sorry, a few things to think through. You'll agree with me, it's been a very fantastic 4 days since Monday through to today. And all this wouldn't have been what it is without all of you. You've been punctual, you've been attentive, you've been engaging, you have contributed, you've let us into your wealth of knowledge, you have asked very valuable questions, and altogether elevated the experience of the conference for everybody. I want you to give yourselves a round of applause just for doing that. Just on a very quick one, it's not going to be a long one, just a few things to quickly say before I do my proper thank you. There's a link that the scientific chair paper committee sent for feedback. Please do engage with the link. I believe it's on the platform for all of us to consult and provide our feedback for the different papers of today, from paper 5 through to the last one. Please do that. It's very important. I also want to kindly remind you, Professor Makodion was here yesterday to solicit our help in carrying out this project for our most underserved sector, workers in that sector, which is the small and medium scale sector. I know a few of you have indicated interest to join the project. We will want everyone to participate in that. You don't underestimate how far your contribution can go. We will have, as was discussed yesterday, another webinar dedicated to the practicalities of what needs to be done. Look out for that as we publish it in the first quarter, the early part of the first quarter of next year. Talking about webinars, we will close from this today, but don't be shocked when we invite you to join one of our webinars again before the year is over to mark off our quarter 4 webinar series. Look out for that. At this point, I want to invite the president. He's got a little ceremony to perform, and I want to invite Dr. Musa Shaibu to the front to launch, as it were, this something, I should just say.
Thank you very much. It's getting to 4, and I'm delighted that we'll be finishing early today so that the reception after the conference will take place. I'm so delighted because looking at the hall, it's filled up. And I can't thank all of you enough. But having said that, the few things we just want to do, because as we're not reinventing the wheel, but it's what we see other societies do. Take for instance, if you look at Jide now, he's wearing a very beautiful lapel, but it's that of ACOM. Jide, can you step forward? Okay, it's not here. And I think Sophon has gotten to a point where we should proudly be seen with ours. We've produced one, and at this moment, I'm going to formally present it to the House. We'll launch it. However, it will be for only financial members. So what we do here today, we have member of Board of Trustee here. The chairman of the board is not here. Member of the Board of Trustee here. And in fact, 2 members are here. Dr. Philip Amoma is here. And Professor Mokoden is also here. You will please step forward. And I would like to invite our guest, Warren Silverman, to also step forward. So for now, as a symbolism of my hand presenting this to you, we are going to decorate members of the ESCO, whom I'm sure are financial members, and members of the planning committee, whom I'm also sure are financial members, to step forward and be decorated. As a matter of fact, the Board of Trustees, you decorate me, I decorate you. Thereafter, every other financial member, you will pick yours from the National Secretary or the financial, as the case might be, because it's your entitlement. Ladies and gentlemen, I want to see you at the airport wearing this. I want to see you at work wearing this. And Jide, I won't ask you to remove that of ACOM, but I want you to wear it side by side with that of ACOM. So, can members of the ESCO please step forward? Yeah, madam, please. Yes. So, I think, where are the members of the ESCO? Ayo, step forward. Let's do this smartly. Jide, step forward. Where are the ladies? Kemi. All right. Folusho. She's not here. Okay. So, I think we'll start from members of the BOT. So, Kemi, you come and you help us dress members of the BOT. Okay. Now, why that is going on, so that we can be more efficient with time. 2 things I want to remind you of that keep your ears open. We are going to constitute the working committees, as it were. However, we are not. However, we are not going to. It's left for you, as you have to volunteer in which of the committees you are going to perform. It is very, very important. So please be on the watch out. Once we name the committees with their terms of reference, we will let you know. And for me, though it's not something that was approved at the AGM, but it is only proper that every member belongs to at least one working committee. Please, you contribute to it and you also learn from it. So please, by the next AGM, I'll be happy to see that every member of SOFON is on at least one committee. That is one. Two, we need to be very active at the various zonal levels. So going back from here, take for instance, the South-South, with headquarters maybe in Port Harcourt, you decide that. North Central, for instance, Abuja, we are there. We should come together, okay? Look at our constitution, have your own set of bylaws that will guide you, and let's see some activities going on. Lagos, the same thing. Sorry, is that done? Okay. Where is Folution? Where is Folution? Folution is not here. So if Folution is not here, they will decorate. Oh, hold on. Ladies first. So, no, you have to be decorated. Hello, ma. I think you have. Come, they have to decorate you twice. If Folution is not here, they'll decorate. So, step forward. So the rest of us, I'll call it Warren. Okay, I will decorate. me. Let me remove his button. National Secretary. So from now on, please, by the time we come back here next year, we should have, each and every person should have been a member of the committee, and not just been a member, functional member of the committees. And then the zonal branches. Let's try to reactivate as many of the zonal branches as possible. As a matter of fact, wherever you are, ask yourself whether the zonal branch for your location has been set up. Otherwise, you can initiate it. All right? Dr. Lulumari, Port Harcourt. Edokus. You see now, Port Harcourt is well said. Dr. Untia is even there. Come on, what else do we need? Abuja. Dr. Shoke. You are here, very good. Okay, myself, I'm there. Okay. Dr. Enuma, you are part of Lagos. Lagos. So please, let's try to do something. Let our activities be more, let's be more active at the zonal branches. That is the only way we can really, touch base with the informal sector. With the project that we are trying to work on, we can only deliver on those projects at the grassroots, not at a SOFON national level. We can't do anything there. I think this, yes, VP, I think at this stage I want to hand it back to the chairman of the planning committee, who has brought all of us here for the last 4 days to formally wind down on ECO 2024. Thank you very much for coming. 2025, sorry. Thank you very much. All right.
Thank you, President. All right, so I know we've just been reminded, for those of us who presented, to please prepare your presentations and write it up for consideration for publishing in the Society's journal. I think that will do a lot of good for our journal. Also, we will be in touch via the WhatsApp group for the next steps in relation to the small and medium scale enterprise risk assessment project that was mentioned yesterday and I mentioned earlier today. Okay, so just to very quickly say thank you again to the Board of Trustees, to the NEC, to the local organizing committees, whom, by the way, should wait behind briefly for a meeting after now. Just a quick reminder, please wait behind for a meeting after now. And to all of you who submitted abstracts and presented papers, whether for oral presentation or for poster presentation. And for those of you who submitted abstracts but whose abstracts was not accepted, thank you. We believe that you will try again another time, and it will be a pleasure to welcome you and to be part of the work you've been doing. One of the other things to say which hopefully you will be excited about, is that for this year, we have been able to confirm the dates and the theme for the 2026 Annual International Conference and Exhibition and AGM. No longer are we going to be waiting till 2 months or 3 months before the conference before you know the theme. And today I can confirm that all things being equal, that conference and the pre-conference and the associated exhibition and AGM will take place as from November the 30th to December the 3rd, 2026. Here, possibly here in the city of Lagos. And the theme we'll be examining will be digital transformation and artificial intelligence, the future of occupational and environmental health practice in Africa. I'll take that again. Digital transformation and artificial intelligence, the future of occupational and environmental health practice in Africa. We hope to see you there. Dr. Warren, we hope to see you there. On this note, I want to say a big thank you to all of you. And just before we go through that door, we crave your indulgence to come around to take a group photograph as a memento to this conference. Odabo, Sandazoa. Oh, that's welcome. What's bye-bye? Sayanjuma. And then what's Igbo for bye-bye? Was it? Komesia, bon voyage. Thank you and see you next year. Bye-bye.
And with that, we've come to the end of the conference for 2025. Thank you very much for your time. Thank you very much for your patience. Thank you very much for your presence and your active participation. Thank you.